Hello? Okay, I think it's now 10 a.m. So welcome everybody to the second National Conference on Infectious Disease Modeling at the German National Academy of Science, Leopoldina in Halle. We are very happy that so many people made it despite the strikes in the public transportation. And also welcome to the online followers. Unfortunately, as you can see, the board is not full today. Berit will join later because she has an appointment at the STIKO. Probably everybody has now heard that she has been appointed to the STIKO, to the newly formed STIKO, and we would like to congratulate her. And of course, we welcome the addition of modeling competence to the newly formed STIKO in form of Berit, but also Stefan Flasch, who is also a member of MONID. I have to say, we understand the scheduling of the STIKO to use MONID, maybe to gain more publicity for the newly formed STIKO. So now to the program of our conference. We start with welcome speeches, a bit similar to the last conference. Then we also have keynotes from some international modeling experts, elevator pitches in particular from young scientists, and this time a guided poster session. Then I'm very excited that we also have a Young MONID session. We will hear about Young MONID later. And then we decided that this conference we will more going in the direction of a real conference. So we have 4 oral presentation sessions and also 3 panels. And I would maybe also, I have one question already to the contacts panels, contacts and diversity panel. In particular, do we have to correct our contact matrices for the strikes in the public transportation system? I think that's maybe a new modeling question. So, but now I think we can start with the welcome speeches, and the first one would be the Dean of our medical faculty, and Raphael will introduce
It's not me, but I wanted to. First, I wanted also to welcome you in this building. We read yesterday the history. It spans several pages, so I will not repeat it. But it's a very nice place, and maybe you will get some information during the breaks. But now I wanted to ask our Dean of Medical Faculty, Professor Heike Kielstein. She's anatomy professor, but also got involved somehow in our modeling field, and I'm very happy that you came to welcome our participants.
Thank you so much. Dear colleagues from all over the world, as a Dean of the Medical Faculty, it is both an extremely great honor and a pleasure to welcome you to the city of Halle an der Saale and in the amazing building of the German National Academy of Sciences, Leopoldina. Creating knowledge since 1502 is the motto of our university. The Martin Luther University, the MLU, offers a wide range of academic subjects in the areas of humanities, social sciences, natural sciences, and medicine. The MLU was created in 1817 when the University of Wittenberg, founded in 1502, was merged with the Friedrichs University Halle. Today, the university has around 22,000 students and 340 professors. The medical faculty, one of the founding faculties of the MLU, offers 5 courses: medicine, dentistry, 2 courses of nursing, and midwifery. More than 2,200 students undergo their academic training in our faculty. And in 1754, Dorothea Erxleben received her MD degree, becoming the first woman in Germany to do so. One of our core competencies in teaching is interprofessional and interdisciplinary teaching and teaching simulation at a very high level. We have the largest teaching clinic and simulation clinic in Germany. This suits perfectly to your goal, strengthening the interdisciplinary, the cross-disciplinary exchange of leading scientists from the respective research disciplines in your modeling network for severe infectious diseases. Infection experts say bluntly that after the pandemic is before the pandemic, and you and your impressive network are extremely important pioneers in dealing academically, adequately with the future pandemic, or in other words, with the future crisis. Last year, you published your third statement on scenarios for the burden of SARS-CoV-2 infections on the populations on the one hand and the healthcare system on the other hand in the last winter. These scientifically sound publications are extremely valuable in times of uncertainty and finger-pointing, not only in a medical context, but especially in a political context. You have also made significant progress by incorporating new data sources, such as mobile phone and wastewater data. I am pleased and a little bit surprised that the research seems to have received the approval of the national and European data protection authorities. I'm very surprised that they approved these investigations. 3 weeks ago, as my colleague Rafael Mikolajczyk said, I had I was part in one of your projects, not as a researcher, but as a test person. I was part in the Restart 3.0 project here in Halle. This was amazing. I'm very impressed by the variety of topics, the large number of contributions, and the scientific excellence of your conference. I believe that you will have a very enriching scientific and also personal exchange. I hope that after this highly interesting conference, you all will remember the city of Halle as a traditional, cosmopolitan, and international, and scientific inspiring city. I would like to express my gratitude to the local organizers, to Professor Mikolajczyk and Professor Kuhlmann and their team. I'm very happy that we have here the second national conference on infectious disease modeling here in Halle, and I hope this will not be the last time you will be here in this amazing city. Thank you very much.
Thank you very much, Professor Kielstein. And next will be then a greeting speech from the Parliamentary State Secretary Mario Brandenburg. And it's really a great honor that we received a welcome speech from the State Secretary again. And now we will play the video of his welcoming speech.
Sehr geehrte Frau Professor Neyer, sehr geehrter Herr Professor Kuhlmann, sehr geehrte Frau Dr. Lange, sehr geehrter Herr Professor Mikolajczyk und sehr geehrte Wissenschaftlerinnen und Wissenschaftler. Nach dem erfolgreichen Auftakt im vergangenen Jahr treffen Sie sich heute und morgen zur zweiten Jahrestagung des Netzwerk MONID. Inzwischen sind Sie Ihrem Ziel einen großen Schritt näher gekommen. Deutschland hat sich in Europa als wichtiger Wissenschaftsstandort für die Modellierung schwerer Infektionskrankheiten etabliert. Ich freue mich daher ganz besonders, Sie im Namen des Bundesministeriums für Bildung und Forschung begrüßen zu dürfen. Das Ende der Pandemie mit allen damit verbundenen Einschränkungen des täglichen Lebens liegt nun knapp ein Jahr hinter uns. Rückblickend betrachte ich die Corona-Krise auch als Chance, um daraus für den künftigen Umgang mit Krisen lernen zu können. In dieser Krise sind wir ein Stück weit über uns selbst hinausgewachsen. Ihr Netzwerk ist hierfür ein eindrückliches Beispiel. Wir haben vieles gelernt aus der Pandemie. Vor allem haben wir gelernt, dass wir eine solche Herausforderung nur mit vereinten Kräften bewältigen können. Im Netzwerk MONID ist es Ihnen gelungen, die Modellierungskompetenz zum Thema schwerer Infektionskrankheiten in Deutschland erfolgreich zu bündeln und nach außen sichtbar zu machen. Aus dem anfangs vielstimmigen Chor der Modelliererinnen und der Modellierer ist nun eine Stimme geworden. Eine Stimme, die als zentraler Ansprechpartner der Wissenschaft für Politik und Gesellschaft dient. Dass diese Stimme auch in Zukunft für uns unerlässlich bleibt, steht außer Frage. Infektionskrankheiten zählen zu den häufigsten Todesursachen. Immer wieder tauchen neue Erreger auf, die im schlimmsten Fall neue Pandemien auslösen können. Nur auf Basis hochwertiger Modellrechnungen wie der Ihren sind wir in der Lage, darauf auch in Zukunft frühzeitig und angemessen reagieren zu können. Die Verfügbarkeit verlässlicher Daten ist dabei eine große Herausforderung. Ihre Modelle können nur so präzise wie die Daten, auf denen sie basieren, sein. Hierbei profitieren Sie unter anderem von der Kooperation mit dem Robert-Koch-Institut und dem Netzwerk Universitätsmedizin. Wir setzen mit unserem KI-Aktionsplan klare Akzente. MONID geht hier mit seiner KI-gestützten Datenanalyse bereits voran. Ein besonderes Augenmerk legen sie zudem auf die Nachwuchsgewinnung. Die Young MONID-Initiative begrüßen wir daher sehr. Mit diesen weiteren Vernetzungsaktivitäten tragen sie wesentlich dazu bei, die Modellierungskompetenz nachhaltig zu stärken und unsere Pandemic Preparedness zu steigern. Auch zukünftig bleibt das für uns ein wichtiges Thema. Für heute wünsche ich Ihnen daher eine gelungene Konferenz und weiterhin eine erfolgreiche Zusammenarbeit.
Yeah, thank you very much again to State Secretary Mario Brandenburg for this welcoming speech, and we highly appreciate the support of the State Secretary for this conference and also for MONID. And as he already mentioned, last year we started to intensify our cooperation with the RKI. We conducted a joint workshop in which we talked or discussed different aspects such as data management, also data transfer, and of course maybe joint research topics for the future. And so it's my pleasure also to welcome the president of the RKI, Professor Dr. Lars Schade, who will give the next welcome speech, also per video but live. No? Okay, so unfortunately I heard the next point will not be the welcoming speech from the RKI president, but since we are of course highly flexible as our models, we will continue maybe with a welcoming speech from the MONID board, and I would like to present the highlights of the past year. And then hopefully Professor Schade joined the conference. So I don't know, somehow this is fine, but I cannot see. Sorry? I wanted to see my presentation.
Ich habe die RAM gespielt, die geht nicht auf die Leinwand.
Ach so.
Ja.
Okay, so, and how, so the audience will not be able, and how do we get the presentation on the screen? Not at all? Do we get any presentations on the screen today? So, I mean, that would be a problem. Okay, so unfortunately then, maybe I have to tell you what you should have seen on the slides. So the first point would be some research highlights. Second point, our joint modeling activities. Third point would be informing decision makers. Fourth point, Young MONID. Then the fifth point, the first national conference on infectious disease modeling, the summer school 2023. And which you cannot see, which is really a pity, is the new MONID logo. Okay, I prepared a few jokes for this new MONID logo, but I don't know. Okay, so the first one would be the research highlights. I don't want to highlight any particular research projects because all the highlights will be presented at this conference, and we have had over 80 abstract submissions. We have around 24 oral presentations, over 50 poster presentations, 15 elevator speeches, and from MONID alone, we have around 21 oral presentations today, 13 from young scientists, so over 50% presentations from young scientists. We have 40 poster presentations from MONID. Of these, 33 from young scientists, and then we have 13 elevator speed pitches from MONID and also 12 from young scientists. So what you also should have seen on this slide are two pictures from two of our research works. One is a modeling exercise on the side effects of the European Championships, and the other one would be a picture of Restart 3 featuring die Prinzen. Unfortunately, you cannot see the pictures, and what I wanted to say, please don't worry. This sustainability concept of MONID does not include entering the event industry, maybe at least until the next pandemic, and when our modeling teams probably find out that only the events organized by the MONID Event GmbH are safe during pandemic times. Yeah, the next point would be joint modeling activities. So also in the last year, we conducted a joint modeling on the burden of COVID-19 and other respiratory infections in the winter of 2023-24. For COVID-19, we simulated 4 scenarios with high and low population immunity and also with low and increased hospitalization risk. And what we found is that over the winter, there would be a moderate hospitalization burden due to COVID-19, but high shortages in staff and personnel. And then we also looked at RSV, at least one model looked at RSV, and this model found that the infection numbers would be comparable to the past season or to the 2022 and 2023 season, but with a later peak. And I think that's what actually also happened this winter. Then we also inform decision makers. We have the Modus Covid BMBF reports, and we have contributions to the national vaccination and public health committees, and also conduct modeling to the ECDC. Also in the past year, one of the contributions to the national vaccination committees was a MONID work on the effectiveness of different adult vaccinations against pneumococcal disease, and the model we developed for the Standing Vaccination Committee, I think it was a really important contribution to the later recommendations which were published last year. Then the next point would be Young MONID. I have to say I'm really excited to hear about Young MONID later. It's a great initiative which has been started last year. I wanted to show a picture of Young MONID and wanted to make a joke about our nestlings, Rolf Kaiser and Till Krüger, who also somehow joined the Young MONID initiative. I mean, that should have been a joke, but you cannot see it here, unfortunately, as a picture. We, of course, the steering committee highly appreciates this initiative, and as I said before, I'm really excited to hear more about Young MONID later in the session. Then last year we had the first national conference on infectious disease modeling. This was probably the largest gathering of modeling experts in infectious diseases in Germany so far, with more than 120 participants. But this year we have already more than 160 participants registered for this conference. So I think we will increase the numbers hopefully each year. Then I would like to thank the InfoExpand research group for organizing the MONID Summer School in 2023 on infodemics and pandemics, which I think was well received by all PhD students in MONID, and there were a lot of highlights and exceptional speeches during this summer school. Yeah, I wanted to show you the new logo. I don't know if you can remember the old MONID logo, but this is a new one, and it looks very similar to the old one. I'm I think I shouldn't tell how much money we spent to come up with this new logo. No, we didn't spend much money, but we worked together with some design companies. But later we found out that our initial idea we had with MONID and in MONID with the logo was then the logo which was preferred by most members of the steering committee. So we only updated it slightly, and it maybe also shows that with MONID itself we go completely in, or we go in the right direction, and maybe we have to change or only a few things here and there, but maybe the basic idea of MONID is great and go in the right direction. Okay, then I would like to give you further conference information. If you Twitter about the conference, then please use the hashtag MONID 2024, everything with large letters. There will be 3 presentation prizes for young scientists, 2 poster prizes, and 1 prize for the best oral presentation. And the audience, so you, will decide on the winner of the oral presentation. So please scan the QR code on the conference information and then vote for your favorite presentation, and you have only 1 vote. And maybe also one important thing, you can decide on the music during the get-together by adding songs to the playlist. And for this, please also scan the QR code on the conference information, and we will use Spotify to do this. So thank you very much for your participation in the conference. Now I wanted to make a joke again about the old logo and the new logo, but this also does not work. And now my question would be, did the RKI president join? So, okay. Yeah, then thank you very much.
Hello, everybody. Is it already my turn?
Yeah, hello. We hear you very well.
Okay, hello, good morning. So, dear organizers of the conference, dear colleagues, welcome to everybody at the Leopoldina in Halle. As the president of the Robert Koch Institute, National Public Health Institute in Germany, it's my great honor and pleasure to welcome you to the opening of the 2nd annual meeting of the Modeling Network for Severe Infectious Diseases. Unfortunately, I cannot be with you in person today because of conflicting commitments here in Berlin. But you will have the chance to meet and talk in person to colleagues from our institute, including some of our modelers in Halle. Let me use this opening address to briefly reflect on what MONID means to the wider public health community. As we have entered March 2024, it is important to remember where we have found ourselves 4 years ago in the midst of the unprecedented COVID-19 pandemic. The colleagues in the laboratories and in the health authorities were working hard to collect and analyze the data. The modelers were setting up their models to try and understand the viral dynamics and epidemiological impact of this newly emerged pathogen that we call now SARS-CoV-2. And society at large was looking to adjust a rapidly changing situation that impacts virtually every aspect of our daily lives and the economy. Since then, modeling has been used widely to help design and evaluate outbreak response strategies in real time. Indeed, a network like MONID would have been very useful to have it early in 2020. And if it wouldn't exist now, MONID would have to be established today. And this is not just a lesson learned from the pandemic or speaking in hindsight. Rather, as many of you will know, over the last 3 years, there has been an H5N1 avian influenza panzoonotics that poses a major threat to wildlife and potentially also to human health. The epidemic threat is real, the urgency to prepare is high, and it will rest with the epidemiologists and modelers to work together for science-based advice in support of the best course of action for outbreak response. It seems clear that the question is not if we need to call upon MONID to help protect and preserve the public health in Germany, but rather when. Looking back over the last couple of years since MONID was created in 2022, important progress has been made on modeling in Germany. At the Robert Koch Institute, we have created a new Center for Artificial Intelligence in Public Health Research in 2021, which a number of modelers using the latest AI-based technologies. And we have established a small but permanent vaccination modeling team in support of the Standing Committee on Vaccination Practices, so-called STIKO, in 2022. For those of unfamiliar with it, this is our National Immunization Technical Advisory Group. And this is existing in Germany over 25 years since 1972. As just about a month ago, the Federal Ministry of Health has appointed Berit Lange and Stefan Flasche as new members of the STIKO, two esteemed individuals from the MONID network. All of this is leading us to the path that strengthens both public health as well as modeling in Germany. And so, let me elaborate on three aspects that might be of importance for MONID in the near future. Firstly, at Robert Koch Institute, we have taken a great interest in the joint scenario modeling for respiratory pathogens by MONID that you have been published in the last 2 winters. It is testament to the collaborative nature of MONID to have modeling teams from across many different organizations and institutes come together and contribute their results. Similarly, model forecasts have proven pivotal for situations awareness during the COVID-19 pandemic in Germany, Europe, and beyond. The value of forecasting has gained immense momentum since the pandemic. But even before that, the idea has been successfully applied to other infectious diseases already, for example, in the USA to forecast dengue or the West Nile virus. At Robert Koch Institute, we look forward for MONID to expand into these new areas of applied epidemiological research. Secondly, it is vital to continue building the capacity of infectious disease modelers in Germany. When I look at the group picture of the last MONID conference, I see many faces familiar who have engaged in modeling for many years, if not decades. But it is promising to see the diversity in the many new faces too, who have only started to engage in modeling infectious diseases. I want to encourage you to continue in this area as your skill set is urgently needed in the years and decades ahead. It is for this reason that I have taken great interest in the so-called Young MONID initiative for early career researchers to make MONID sustainable and innovative. The initiative also aims to provide opportunities for training and education to allow for the transfer of knowledge from experienced experts to younger generations and vice versa. This conference is a prime example for the pursuit of these aims, and the depth and breadth of the expertise gathered here in the Leopoldina today is a testament to you living up to this goal. We at Robert Koch Institute look forward to see the expansion of these training and education activities. Thirdly, let me emphasize the importance of collaboration between our colleagues working in applied epidemiology and surveillance and the modelers working with the data. Without high-quality data from the real world, the usefulness of many models would be marginal. What is more, we need to foster the knowledge translation between epidemiologists and modelers as it is simply not sufficient to make a model fit to the data. Likewise, the trade-off to keeping models as simple as possible but not simpler, to quote Albert Einstein, can lead to models being unable to sufficiently capture complex disease dynamics and processes. You are modeling infectious disease dynamics to better understand the relationship between observations, like infections or hospitalizations, and processes, like transmission dynamics. But I understand that it can be challenging to account for both observation error, for sampling variation, and process error from the underlying mechanisms that contribute to the observing the outcomes. And it is indeed not always necessary. What we do need, however, is a greater dialogue to better understand how the models can reflect the data and how the data can inform the models. Our joint workshop between MONID and the Robert Koch Institute in October last year was a great start to foster this culture of joint collaboration and strategic vision that continues in the background. Let us recognize the value of early involvement in sharing insights, knowledge, models, and data. It is, from my point of view, imperative for MONID to nurture the culture of collaboration and empower individuals and organizations like us, but not only us, to drive meaningful impact in public health. It will also be key to remain agile and to seize new opportunities and address emerging challenges, including outside of acute respiratory infections. With that, I thank you for your attention and the invitation. I wish you a successful conference that promises to be full of exciting talks and with space for fruitful discussions and exchange. Thank you.
Yeah, dear Professor Schade, thank you very much for the great speech and also for always supporting MONID and our conferences. Of course, in the future, we're also looking forward to intensify the cooperation with the RKI, which is, I think, really one of our most important partners because it's the most important public health institute for infectious diseases in Germany. So we're looking forward to the joint projects and also the other initiatives you already mentioned and which we discussed in our joint workshop. I think there will be a lot of joint events coming up, hopefully this year and also next year, about different disease topics, ideas, and joint projects. Yeah, so thank you very much. So now it's my pleasure to welcome Dr. Julia Fitzner. She will have the first keynote of our conference. Julia is a medical doctor and epidemiologist with 25 years of public health experience with a focus on enabling data reporting and analysis from different sources. Julia worked now for the WHO for over 23 years. And has an extensive working experience across different levels of the organization and disease programs with a focus on global surveillance data collection and analysis. She also co-founded the WHO XSmart system to harmonize data sets, reported to WHO, has led the burden of influenza disease work and was responsible for the WHO COVID-19 and influenza data. She has also been involved in several global crisis responses, including yellow fever outbreaks, SARS, the 2009 influenza pandemic, MERS, the COVID-19 pandemic, and the monkeypox outbreak. Julia has been supporting the WHO Hub for Pandemic and Epidemic Intelligence from the early concept and is currently the unit head for Insight and Analytics. She graduated from the Charity Medical School and did her field epidemiology training at the Robert Koch Institute in Berlin. So, yeah, thank you very much for joining the conference.
Thanks, Alexander, for this nice introduction, and thank you, everybody. I think, this is such a wonderful day, a wonderful place, and I think also a wonderful opportunity because, as you will see throughout my presentation, this kind of collaboration, building networks, and working together more interdisciplinary is really on the heart of my passion after all this kind of work that I've done so far. Always and I really think this is a great opportunity to move forward with the idea. So I'm very happy to have this network, see this network grow, and also see some of these excellent outcomes. So as Alexander was saying, I'm currently working in Berlin, but it's a WHO dependency from HQ Geneva in the Hub for Pandemic and Epidemic Intelligence. And I just want to sort of start a little bit with, while we keep on saying we are coming from COVID and now we are having sort of peacetime going into the next, but it's not really true. The world is going on with infectious diseases. There are lots of things happening, and we keep on needing the insights in all these different emergencies. So just in 2023, and those are not all, that's just some examples of highly severe diseases that happened and that we needed to respond to at the global level, but that also impact, I think, German and national things as well at some time. So there was dengue, or there is dengue, actually. It's been growing up in a lot of countries, and it was already mentioned. The influence of climate there obviously is there, so we also need to look out where it's going next. We do have quite a lot and a huge part of cholera. It was mentioned already, the avian influenza part, H1 and 2 now in humans, but there was also mentioned the rising of the avian influenza by Lars Schade of H5, which is not yet a human-to-human disease, really, but it's the likelihood seems to be coming closer and closer. We do have a lot of displacements, which in itself causes a lot of problems for infectious diseases. We have Nipah, we have diphtheria, we have these kind of conflicts which don't seem to end, as well as West Nile. So just give an overview of this type of work. So we have a system to grade health emergencies, which means sort of that they're graded and that we take action on them. There were in 2023, there were 43 graded infections where sort of the headquarter would intervene as well. We had 60 affected countries and 166 million people that were in health assistance need for those graded systems. So in general, and it's sort of it's how do we get the good surveillance, the good analysis, timely and better insights for analytics. There has been already quite a lot of things that are going on, and this is not new. We are looking into the signals. We are looking into things that are happening. So we have the public health intelligence at WHO. We have 164 country offices. We have 6 regional offices, and we have HQ. And we are, every month, we are looking in information on, is there something happening, and could that be something that is coming up new? So there are 9 million pieces of information that are analyzed, signals are scanned, and relevance is identified, and events are highlighted, and finally, we come to these new events that are verified. The numbers are exemplary. This is a daily work of lots of people and lots of systems, including modeling. And this needs to then be taken to the more traditional surveillance systems as well. And there are different surveillance systems with different objectives, with different analysis that is needed to take them onward. So we need to detect, we are detecting new diseases similar to COVID or SARS. We are also needing to look into things like mpox, where there is a reemergence of the disease. So it's been there, we knew about it, but suddenly there are different things that are coming up. We also want to monitor and we want to see how measles is doing. And obviously we want to eliminate finally polio. This is actually, when I started at WHO, we were supposed to have ended polio. That's quite some time ago, but I think we're getting there. and I think looking forward and looking for those hotspots for the last sort of things is really something we want to go forward with. So in terms of what do we want to look at with surveillance and analysis is one, really detect the threats as early as possible so that we minimize health effects of disease outbreaks. So stopping the worst before it actually happens. We also want to continuously inform decisions for better population health. So really taking a better decision based on the information, analysis of that information, and bringing it forward. But then also to see a little bit what are our options? How can we stop? What can we currently do to sort of avoid the worst turns during emergencies? The other thing, which is complicated and which comes again and again, is this constant uncertainty on what are we facing, how do we face it, and what kind of decision can we take. But then also for the decision makers, or actually it's not only the decision makers, it's also the decision takers, which is each and every one of us, is what and how should we react to these informations. Obviously, the uncertainty before any pandemic, also pandemic and epidemic, is which pathogen is the one that is now going to jump up. I mean, as we mentioned just before, H5N1 has been on the radar since a long time, and it's creeping up. If you would take the notice of signals, we are on high alert for H5N1. But because we are tired of high alerts, we also don't really care so much currently, or maybe we don't need to, but it's difficult, we don't know. And then also during all this time, when we look back to COVID, who would have thought, or Omicron is a good example as well, who would have thought that all these changes in one genome would have happened at the time? We did not foresee that. And we have to be honest that there are things that with the current methods that we have, we cannot predict. But we then need to be ready on what needs next and how do we react. And so it's really taking then, during the pandemic, epidemic even, what kind of things can we do to mitigate? How do we need to react and how can we better be prepared? Lots of things where we need data and analysis for, and specifically joint analysis, I think. So it's I'm going back to those 3 steps and sort of where do we really need then the analysis and modeling for it. And it's for this detecting threats early, we do need to, and we can use all these possibilities now to identify hotspots where we should do more surveillance, where we should be aware of, where we then can find easier if something is happening. And it's a good example was mentioned already with dengue, for example. Dengue with the heat waves, I mean, modeling climate change and looking into it does allow us to foresee where outbreaks are likely to happen and hence intervene in taking out some of these niches for the mosquitoes and hence to reduce then a bit the amount of the epidemics. It also then can help to see why is a hotspot there and why is not a hotspot there, to compare them and then take action accordingly. The continuously informing, and you're all aware of those different things, but it's sort of this nowcasting, the predictions, the forecasting that was mentioned, the understanding of burden and risk factors and groups, and really then to prioritize intervention for whom, when, how much? And then sometimes, I mean, also to sort of balance, is it rather this group that we can give the prevention to, or should we use it for this one? Those are important analyses that help. And just to also say a little bit, during COVID, the modeling network, in hindsight, often has been, any modeling has been criticized for being not right. And it's true that if you actually take all these, look at a lot of the models, we weren't, or I'm not the modeler, I'm only using the models. There were a lot of wrong models. There were a lot of models that went off completely. But comparing and being able to see, even a wrong model helped to make decisions. And I think this is also something that we need to stay forward. We don't always have to be right, but we have to make the comparisons and learn how to improve and communicate on what our uncertainties are actually. And this brings a little bit the scenario planning as well. If we have two options, we have a forecast and we have two options or three options. Is it school closure? Is it mask wearing? Is it vaccination? How do they interact with each other? How can we compare? And this makes it really difficult with using different models often, because we have a very different outcome. And then as a person that then receives those models and results, it's sometimes really hard to take a decision based on the evidence, and then people go and just take what is closest to them. And I think that's something where we need to work on. So coming to this really complex ecosystem where many, many things are interacting, because it's not only just the disease outcome. It is not only the way that our body will react to a disease, but it is actually the genetics that make a difference, the genetic of the genome, the genetic of the person that is that is gonna be infected. We have the animal characteristics, and just before joining the call this morning, there was the cat, the Poland cat sort of incident mentioned for where we have cats now that infected each other with avian influenza. And it's how much can we then look for other animals that might also get it? How do we interact with these animals, and how is then the risk for humans greater? We have these public health events, as mentioned, and as more known, but it's also the demographics. There might be niches of people that are really reacting differently, and we need to sort of interact all this information in order to make the best model possible. I'm now showing a bit the surveillance data, and I keep on being a little bit disappointed of myself, because as Alexander was mentioning, I was among the people responsible for these data. And yes, it's a nice data. It does show how the pandemic has been working, but we know how wrong a lot of this data actually is. And actually just putting it together and putting it on one line does not mean that at this time the infections were always bad or good. And it doesn't mean that showing this kind of epidemic curves, they help, and forecast also helps, but they are not all of it. And it also, this is a little bit the story then on why and how we meant also at WHO, similar to the MONID, bringing in the MONID as a network. We think that we need to sort of do something more to think about these complex things together. And this is a picture, it's not from ourselves, it's not from me, but it does show, I think, how all these interactions are really, you can imagine, probably not all is right, but you can imagine how complicated things are and how data and results of data really interact, because it wasn't only the disease, and we have one string line and it's that many diseases, but it's the reporting of the diseases. It's why are you not going to be reported, because you have economic loss if you don't go working, if you report you have a problem because your kid doesn't go to school. There are so many interactions that actually the numbers that we receive on how many people are sick doesn't necessarily reflect easily what we are seeing. But the person, and this is bringing in the context into those data, which is really complicated, and I don't think we are there yet, but I do think that with modern technology and lots of interactions between different disciplines, we can get a lot closer in understanding this. And there have been a lot of innovations, and we are profiting from that, and we should use it. So during COVID, there has been a lot of new the genetic sequences. As Alexander was saying, I've been working in influenza for a long time, and we have not really had even the littlest of the amount of genetic sequences that we have now for COVID. I mean, it was amazing. And while we might not need all of them, it was really helpful to understand how the different clades were evolving, how they were rotating. We were able to make models and predictions on which ones will be the likelihood of some, and we were able to link them to some of the severities as well. There's also, and this is, I think, great, there is so much repositories in open accessible parts where code of models or tools to do analysis are actually put forward, and you can access them. And while this is wonderful, it's really difficult to scan through them. What is the usefulness of each of one of them? How can I use them? And then most of the times we restart, because if you need to do something, you take your own model, even though you could find a better one somewhere, and you don't. It's difficult to put them together. It's difficult to find what you want to do. And so I think we need to find ways on how to work this better together. This is already a great start to put it openly, but I think we even need to go further. And there are ideas about the UN Data Commons. There are groups like Epiverse. I don't know if you heard about them. They are trying to package them, bringing them forward, and really, I mean, these kind of networks are great to then communicate and put together different codes and understand how they would work together, and how to judge them so that we can use them more effectively and not just have them open somewhere, but actually have them reused and not only published. I'm going back a little bit, and this is it's an old example, but I do wanted to show a little bit from where I'm coming from also on how complicated even joining analysis is as well. So this is from the influenza world, and we were, as you might or might not know, we kept on having this one estimate of global influenza mortality, which was 250 to 500, which was based on a FAQ mark. All old influenza publications are based on this very one number, which was a back of the envelope calculation. We then kind of said that we need to see what other models are there, what does it really mean, and there were 3 global estimates. And as you can see, the numbers are quite and very different, even though they're really renommated people doing the modeling. They were good models. And then if we would just do an ensemble model and compare the mean, it would be a huge range, and we would not be able to do anything with it either. And so we actually went and tried to understand what the differences are, and to come up with then a WHO estimate that would be more realistic, let's say. And while in the end, as you might see, the CDC, around the CDC estimate was finally the one that was used. The difference, for example, for the IHME one is really it's not a wrong estimate, but it's the way that it was calculated, only taking a small bucket of the data and expanding them. It has changed since, because some of this really going into the inside of the model with the different modelers. So all collaborators went and really discussed each and every step of the model, and then came up with this consensus model estimate. And then the other thing was then, how do we communicate this new model, which in the end wasn't really different to the old back of the envelope one, but it was only the respiratory disease estimate, which in influenza is actually only a fraction. And so we try to make pictures of that it's only the little one in there and not the overall estimate. And this is sort of like the previous estimate being the small one of, and then the new estimate is inside of a global burden. While trying to be better in communicating, I personally think that we actually didn't do too well. I don't think that a lot of people remember this one, and the old one was so much easier to remember everybody. I still read in a lot of publications exactly the old one. And it might not be needed, but what I wanted to show as well is we need to really go into the details of a model and of the analysis to understand the differences. And this difference, and this is exactly what we need to open up others. We need to peer review each other work, but really being open to the inside of it and not only to a publication, because otherwise it's not easy for people to understand that even have the technical expertise to understand it. And then similarly, a different way of moving forward, and this was already, we started this during COVID, was we called it the situation of concern analysis, where we started to use the analysis with a model, and then took the model and sort of the ranking of the model and analyzed it against the insight of the people that know the context. So we actually we ranked which country is currently likely on a high alert of having a new outbreak or a new, actually it was more and it was based on the India problem that we had during COVID. I don't know how much you remember, when Omicron hit India, we had the issue that we didn't have any oxygen at all. And we were failing to bring oxygen to the patients. And if we would have, and in hindsight, we all knew that we could have known this problem before. And so we wanted to anticipate this kind of lack of resources in the hospitals earlier. And so that was sort of the action on how we could do it, because it's not only analyzing the data and predicting, but also understanding the context. The context, like, is there going to be a mass gathering soon? Is there going to be mass movement soon? What are you thinking in-house to it? And then it worked. It was, we kind of put it on the watch lists of doing those kind of things. And an example, for example, was Romania, which we were then able to, in the Delta wave, to really put on this watch list earlier, make them react on it and be prepared better. And so there, at least the respirators and oxygen supply was better prepared. Not that we did it all good, but it was a better start, I'd say. And similarly, we've been looking into cholera outbreaks to prioritize on which countries do we look out for in the response? Where do we need to go? And which is not only driven by the data, but also data of the disease and is it there, but rather on how we really look into each of the possibility to respond to a potential outbreak as well. So this brings me to sort of, we need just this better analysis and in pandemic and epidemic intelligence. And I kind of came through different parts of it, but it's really, we have data, but it is all over the place and it's not good used. We have, if we go back to COVID, there was a lot of data that was available, even publicly. And I know we keep on saying we don't share enough data in good quality. That's all true. But even if we would have used all the data that is already available publicly and triangulated and used it better, I think we could have gone a long way. And I also strongly believe that if we do that, openness to share data will change, because if we show how data is used, we will also be able to do it. So I think it's not always only the call for more and better data, but it's actually also on how we use and show that the use of data is actually useful. And this is something where we really need to work together on finding the data, making it available, but not only making it available somewhere, but actually make it findable and usable again. And then, as I said before, this context of the information is often missing. And here again, talking of my own misdoing, we were collecting the COVID data at HQ, and then we got a lot of requests, kind of like, share the data, give us the data, we'll do the analysis, which is true. I mean, there are so many great people doing and knowing how to do good data analysis. But a lot of this kind of site information, why some of the data was different, even though it was all joined, was not added to the data in the best way that we could have. For example, Mexico was only giving data on people that were hospitalized. So their mortality rate was a lot higher, and everybody that analyzed that data set would just come out with, Mexico has this high risk. But we knew that that was not that reason. But putting all that into the data is also a problem. So talking to the people that actually collect the data and do the analysis with the people that actually have an interaction with the data is an important thing. The analysis then, and this is the next thing, the people that have the data often don't know all the possibilities to do the analysis the best way. So bringing those people together, the people that know the context, as well as the people that do know how to do best-in-class analysis, is something that we think should be done. We don't find the relevant models. That's what I said before. There are so many things out there, but using and choosing what to really use is not an easy thing. And then the next part, which I think we still have to really learn on, is doing a more federated approach of analysis, that we leave the data where they are, but that we offer the ability to actually then do the analysis, help centralize analysis, but leaving the data where it is. And then this has been mentioned a lot again as well, and I think this is great news that everybody understood that we need to communicate the data to the decision makers and takers. I have to add here as well, because the insights often don't respond to what the decision makers need to do, or they don't come at the time that you need them. And again, in COVID is a good example. We were the SAGE committee, which is how to immunize the STIKO sort of for WHO. They asked a lot of modelers to help them identify how to best do the recommendations, and the models that would have informed just came a year later. And so this is exactly the point as well. We want to be perfect, but it in the end doesn't help us to take then the decision. And often, and this is what I said before, the conclusions that are not understood easily, and we are the people making those good models also need to be the brokers of the information, I think, for the decision makers, and be clearer on how to read them. And sometimes they are even not shared, but I think that can be helped sooner. And then, and we don't have, really the results are not comparable sometimes, because you use different age groups, you use different groups in total. In general, and this is now sort of a little bit of bringing it back to where WHO is going in making all that a bit stronger, really focusing on the so-called collaborative surveillance, where we bring together the different areas, the different dimensions, so that we work together and get a stronger rope. So each of us is strong, but we will be stronger altogether, really connecting the capacity of the tools and the skill sets, and capacity building is a huge thing in that, but also accessing the new data sources and improving the technology and the platforms. And so a little bit of my current work, where we are going, is we are trying to build a laboratory for collaboration, where the vision would be that where we are interconnected, for the epidemic intelligence and collaborative and rapidly respond with enhanced data, better analysis, and actionable insights. And it's sort of then bringing the data better together, showing where they are, having the possibility to trusted networks to share data, results, and information, and including this context data, that we have an improved analysis where we have joint analysis, transparent, reusable, and comparable, and hopefully even federated analysis that we can use, but then also that the analysis are used for decision making, but also that the analysis is actually based on the questions that the decision makers have. And so coming back to this thing, we do believe that it needs two things. It needs these communities of practice, and one of them I would think is the MONID, for example, that are already working together, sharing results. And the nurturing of these communities of practice is absolutely important, and they need to stay a little bit where they are, but they need to connect to other communities of practice that are trying to do the same work, so that we can use, sort of from WHO's perspective, we want to use the convening power we think we have, to strengthen these communities and enhance even the collaboration with others, enable connections and exchange between experts, because often it is sort of like, okay, who has an idea about this possibility? How have you done? It helps so much. And this we've been working with these kind of networks all along, but how can we ensure that it's not I know the person, but that we actually bring it that we make it easier for people that might not have the possibility to come to conferences, that are a little bit more in lower resource countries or settings, because even in our very high income countries, some people can have good ideas, have good data, but they cannot participate and get to know the people around them. How can we make this more easy accessible? And then share the information and lessons learned, and how can we then co-create analysis, so that it is not, we always use the best in class, I don't know, the one that always is the loudest, that has the most publications, but actually that we co-create something together that we can then all use and understand. In order to do that, we are trying to really build an infrastructure, a digital infrastructure that would allow this kind of joint analysis easier, so that we have collaboration on the tools, that we find the tools easier, that we enable that tools are put, like on GitHub, but also that we then find what it means, so that we have metadata around it and can judge a little bit easier. Same for the data. There are so many data out there, as I said, but it doesn't help to have it everywhere and not to find it, because then you just start from scratch again and collect it. We still need even more and better surveillance. I don't want to underestimate that, but I do think that we can already do a lot with what we have. And as I said, a little bit this library of tools, and also access to analytic platforms, because a lot of times it just does take a lot of computing power to do good models and good analysis, and this is sometimes then also a hindrance for people that might not have the resources to do so. And this then brings together the collaborative analysis, where we have the digital environment for the ease of access, a sandbox, a data set that is actually alike. And coming back to, for example, the analysis that we did for the mortality estimate of influenza, it was just the pure population also that was used differently, and in order to expand to the global setting. So if you at least use the same, even you might not want to publish with that one, but if you can take it, that's an important thing to move forward. The technical integration and also benchmarking to do that on the digital environment, and then on the community again to use the technical expertise, the knowledge sharing, as well as really connecting people. As an example of what we are starting, and we are also trying, and I think we want to learn and engage with people like you on how we best do that. But I want to give an example of one of our initiatives, which is now the repository of the epidemiological parameters. So what we've seen, or what we keep on seeing, is that there is not, when an outbreak starts, we want to have all the epi parameters in order to do some of the analysis, and they are not readily available. There are some good reviews, there might be some knowledge, but it's not, we don't have a repository to find where those kind of parameters are stored, updated, and vetted. And so what we try, and we found that that a lot of institutions have been looking into it, and so we are trying now to bring all these different institutions together on having a global repository of epidemiological parameters that is publicly accessible by modelers, epidemiologists, and subject matter experts, as well as actually anybody, but that they can also use then automatically this kind of parameters in their models. And it's sort of, we are now kind of looking into the prioritization of the diseases that we would extract, or that people extract actually, because we are, this is not a work that we do, but we coordinate the doing of the prioritized diseases. There's ongoing extraction of the parameters, storage of this data, and then obviously the maintenance. And one big thing, which I think is another area that hinders sometimes a lot of the good collaboration and easy collaboration, is how do we do the scientific recognition for these collaborations? How do we ensure that people then offer their work and do a review, actually get credit for it, and not only through just having a publication, but how can we ensure that this work that is done for collaboration is recognized and incentivized? I think there are some ideas in general for giving tokens for publicly interaction with others for the disease decisions, but I think we need to work jointly on how we can do that better, especially with academia. So in terms of this epiparameter, so I mean the data are there, the demographics, the epidemiological, the laboratory, the vaccination, so on, and just sort of the epiparameters really then like taking the prevalence of this disease, taking the normal mortality rate, where was it, how was it done, and so on, and then making a better public health decision-making for those diseases. And as an example, just of how that would how we would use it for measles is then we sort of have the data, as you know, age, gender, symptom onset, hospitalization admission, vaccination coverage. And then what we want to know is what is the usual attack rate in this group, what is the secondary attack rate, vaccine efficacy. And then we can, with those kind of parameters, obviously inform better the public health decision making. In this approach, we are really trying to bring, and this was mentioned before again and again, this kind of more collaborative approach, the multidisciplinary and multi-sectorial global community, which we're trying to embrace and probably still need to get a lot better, but it's working with librarians that can actually get us the data, can give us access easier to already published literature on it. The information specialist, because if you want to extract the data, you actually need to have, how do we do this kind of extractions? The modelers, what do you actually need? How do you quote them? And interestingly, we just had the first extractions and people that have done the publications, extracting these data then now for this work, started to think how precise sometimes the publications are. So how can we get also better in bringing out these data in the publications that people are doing? We are working with data engineers to put it together, epidemiologists, the specialists, the disease specialists, because only if you know a bit what you need to look for, and then the meta experts, but also the academia, the private sector, NGOs, research institutes, international organizations, governments, and others, and also from the different levels together. What we are facing is obviously this different technical backgrounds. A lot of times, even if we talk to each other about the same thing, we might not understand the same thing. And I was just if it is, for example, the midpoint of a median, is it the midpoint of the observation that you did, or is it the midpoint of is it the confidence interval around your estimate, which makes a bit difference? Is it the population that has the range, or is it the analysis that has the range? And if you just look into all these publications that have been done, it usually is not specified what people mean. And while this is in lots of other things as well. And people work in silos. They like to, not necessarily because they like, but because it's also easy. One is busy, and it's difficult to actually collaborate again, put extra effort to share, put extra effort to get together. It's effort, and it's time, and it's money in the end. And I think we need to sort of show why we can go further when we break a little bit out of that. The lack of trust, and this is something that we have everywhere. The trust that somebody will steal the data, the trust that somebody will use the information wrongly, the trust that you actually even use the name wrongly is a big issue, and obviously that the incentives won't be there, and the competition for funding and resources. We try to really be open, have a clear roadmap, have attributions of contributions, establish this a community of practice where we can get better trust, and keep on asking what is it that people ask the users that are giving the data, as well as the ones that will need the data. Do joint papers, do joint analysis, and show that the input is actually there. And so we hope we have a shared vision, we build the trust, we enhance the analysis, and we do have then active engagement. And not only the multilateral, but also we start create bilateral collaborations altogether, so that it is more of a longer-term issue. So in terms of this very project, it's sort of what we want to get out there are lots of different ones. We obviously want to have the parameter model itself, which already is more complicated than one would think when just going there. What are the data that we need to extract? We do want to have a standardization of this extraction, the reporting guidance. We want to have standardized lines and formats, but we also want to use AI tools, because if all these extractions are done, it's a tedious work. I think and hope we can get further using and alleviating then the new AI, new large language models, in order to then extract it more automatically, having the parameter stored somewhere, having tools that then use the stored analysis and have some visualization on it, ensuring the quality checks of the parameters. And this is, as I said already, I think we all need together work on frameworks on how this recognition can be done more easily. That working in this kind of things and adding information is not only something that we think is good and that we kind of praise, but that people then get promoted because they do it, instead of having another, that they worked together and moved somebody else's work forward, that's as much promoted as a Lancet publication maybe. And I mean, we've sort of, in general, we are really thinking that we need to be strong on the governance of these kind of communities of practice. So we have the a project governance, that we have the ethics right, that we have the governance of the data right, that we use the policy of the user management, that we use as much as possible open source so that it can be reused and actually distributed, that we have the scientific recognition and that we are disclosing licenses and issues, so on. And we are using GitHub, we are using other websites to move this forward, and maybe one or the other among you would be interested to join that group as well. It's a public one, we are still building up. But we also think that physical meetings are important, and so we do have physical meetings and do virtual meetings, obviously, as well. And this is already then sort of my last sort of slide on an initiative that we are looking into, which is while we hopefully will build and get people like-minded as you to contribute to more models, we also want to sort of work on a tool where we use this joint analysis to show how a projection can, how interventions can then change, how jointly can change an outcome of a disease. So we are thinking of that we actually, in a very multilateral and collaborative way, would have a system where the data comes in and the different models can be tested on how an intervention then would react, and so that the decision maker can go in and can test themselves. Okay, if I close these schools, that'll change this one. If I don't do it, it's going to be a little bit bad, but not so bad, or it's going to be really a good idea and I can open it, or I can move the vacation and so on, and those kind of questions, and so to really bring it together. And again, we're really looking for collaboration on it, and hope that we can find in networks like MONID partners to move forward. And so this is then coming to my last slide already. I'm really passionate about collaboration in advanced analytics, because I think only if we do the joint things, we can move forward and getting the trust of everybody for this kind of things. And it's not only between us, it's actually also between different disciplines. It's the disease modelers, it's the climatic modelers, it is the economic modelers, it is social science people that we need to bring all together to work together on our predictions and sort of reflecting the world in models. And that will then hopefully really ensure trust, or build trust and keep the trust, to get better results, and to ensure that then these results that are done in so tedious work are actually used in the best way forward. It does need extra effort. It doesn't come just because we want it. We need to make an explicit way to come forward. We need to open ourselves, and we will be hurt at sometimes, sort of like people will use sometimes your ideas because somebody heard it earlier and is quicker. And so it's not easy, and it needs to be recognized, and hence it needs to be a constant reinforcement how valuable collaborative work is actually in comparison to only working on yourself. And with that, I want to thank you and open for questions. I was too quick, I guess.
Hello? Hello? Okay, yeah, thank you very much for the global perspective on infectious disease and data analysis. And I think for MONID and the audience in particular, your last part of the presentation on the collaborative approach on data identification, parameter extraction, and making data available to modelers and other researchers is of high interest. And so are there any questions related to the presentation? Okay.
Yeah, thank you very much for this very nice presentation, really inspiring. I really liked also to see that WHO is pushing forward the topic of federated analysis. I think this is, there's a lot of potential in this area. As my group is working in the area, I was kind of wondering whether you, on what you place your analytic platform, which is currently developed. Is there any package, basically, you are currently preferring, basically, how is it going to look like, and things like that. If you could share some more information, this would be really great. Thanks.
Yeah, I mean, we are really moving slowly in that area. We are just we just identified that it is something that we need to do, and I mean, I think we need to just it will be not one, it will be different possibilities. I think we need to go, and this is sort of where we're really currently embracing, and I don't know if you we are really trying to get these kind of experts together to see how we can move forward. And I think, or actually I'm very sure that it's not, we should not focus on only one platform, one package, but we need to bring it together. And the infrastructure needs to be flexible enough and modular enough to do that. We are currently, I mean, the modelers we've been working on are mainly focusing on the classical ones. I mean, an R package and a Python package. I mean, but that's not what or a Julia one. But I mean, we don't need to sort of work on, I think we should be very agnostic to that, but we need, it's not an easy thing to do. But I think small and building up, always with the idea of keeping it flexible and platform agnostic is the way that we really want to go forward. And we are embracing and trying to find partners that can help us move forward in that. So very open to suggestions.
Yeah. Other questions?
I was very much impressed by this collaborative vision, and I wanted to ask how it is going on now. So it is more like volunteer base, or did you reach out already to communities? There will be some call, or how do you plan to organize it?
So we are the idea is really that it is that it's built from bottom up. So we are not sort of making it, and we are reaching out to already existing networks to try to understand what they need and what we can offer additionally, not to sort of replace them, but how we can link them. And for example, the epiparameter one, it was an open call, but it was sort of like an open call in the sense of personal contacts for now. But it's open, so people can join. And we did publish it sort of like on the WHO, in the WHO networks. But we are trying to reach out further, and this is also another area where we are currently looking into and how we can, on the one side, have groups that already exist and are private, how we can open them to other people without overburdening the huge group, but then bring them together and have the interaction between each other. And we are working with some social behavior people on helping us identifying how we can network easier and better.
One follow-up question. I think the Imperial College has kind of formalized collaboration on modeling with the WHO. Yeah, but this is the only one.
So Imperial College, for example, has is a collaborating center with WHO on modeling. That's one way. And we are working specifically with Imperial College on some of these things. But there are quite a lot of others that are not formalized in that way, the same way. So we have in this network now with the epiparameters, we have a group from New Zealand, we have Canada who's highly active, we have the London School as well, and we have some that are like in Colombia, and it's sort of this, a little bit the Epiverse group also, that is the network that we are using, and others, to try to make it more relevant for everybody. And Imperial is the one that is currently really going line by line, sort of a lot of the diseases that that will be in the first version of the epiparameter ones will be coming from Imperial and from Canada, because they had already this project of doing it, and so we are using that part to move forward.
Yes, thank you very much for this very impressive presentation. And I want to offset the gist of my question with first stating that I'm a strong proponent of open data, open collaboration, and other open practices. But one thing that I'm worrying or concerned about is, does WHO care about secondary use of these things? So do we, on another way, kind of create models that someone can utilize against humanity in the sense of developing critical biochemical weapons or methods of propaganda to, yeah, I think you get the question.
No, it's a very clear, and I mean, I was talking about the governance, and it's one of the issues that we need to sort of tackle. The idea is not that WHO is going to stamp any of the things, because then we would hinder and bottleneck. We will not be doing the quality control ourselves. We will not be able to, because we don't have all that expertise. We will always be too late, I think. And so we do want to have the communities of practice to self-govern a little bit these kind of things. And this kind of exclusion of people. We do want to have people that come and join, fill in some sort of disclosure of sign a conduct, and then that would give us the opportunity to then, if we do see abuse, that we have a system of taking them out of the system. So that's really, we've been asking a little, this is not my expertise, we've been asking the legal people in the organization and others to give us some advice on that. And I think it is a very important thing. The same with if we offer people if we actually do have the capacity to have all the, some computing power that we can offer. We don't want people to do Bitcoin modeling on our server. So I mean, it's sort of like, we do need some sort of governance, but it should be as open and as transparent as possible, so that there's no misconduct, but that it's not us that needs to stringent some of the next steps.
Yeah, also thank you very much for the interesting talk. A follow-up to Raphael's question, do you see ways of, as a long-term goal, ways of formalizing the connection between WHO and MONID?
Oh, no, sure. I mean, actually, we are very open for lots of different possibilities of formalizing. And actually, the idea of the WHO hub in Berlin is also to find new ways of interaction exactly with this way. And so there's memorandums of understanding with different groups, there is exchange possibilities, there is also sort of, and this is, I think, very important to sort of have people even coming to the hub or having meetings. We are very open for this kind of collaboration, and yeah, more than happy to think through and offer some things. This is what we want to actually engage with, and why I'm also so happy to see groups like MONID thrive, that we can use then this network to sort of be a part of a larger network. So more than happy if that is possible.
Okay, maybe we have the time to coffee break.
Yeah. And actually, if you know a lot of, I mean, as the person was sitting there, we are still building our teams. So I mean, there's still, if you are interested in being part of the actually group as well, we are also hiring.
Okay, I don't see any other questions, so thank you again for the presentation. And also, please wait one moment. Yeah, thank you very much. A small present from MONID. Yeah, thank you very much again. Okay, now we come to the next point of our program, the elevator pitches. I think they were well received by our young researchers the last time, so we want to do it again. And because we believe in our young researchers, we make it extra difficult for them. I heard some complaints from some senior researchers that they only have 7 to 8 minutes for their talk, but we wanted to let as many people speak as possible at this conference. Our senior researchers, which were selected for the elevator pitches, and 14 of the 15 elevator pitches are junior researchers, young researchers, they get only 1 minute. And they don't get the yellow card and the red card. They are cut off after 1 minute. So please keep your time. And unfortunately, Stefan Scholz is not part of our coordination office anymore, but we use your slides, at least the structure of your slides from last time. So thank you very much for doing this. So we will now start with the first. Okay, the first one is missing, so we didn't get it because of the strike. So we will already come to the next elevator pitch, and it's I don't know, it's difficult to read. It's Anna Fome, analysis of a competitive respiratory disease system with quarantine. Okay, thank you very much. Epidemic thresholds and cross-immunity effects. So. Okay, now you have 1 minute. So.
My name is Anna Fome. My research just delved into the dynamic of competitive respiratory disease system with quarantine. And for this part, it was just to present the cross-immunity effect. So by using mathematical and computational model, the aim of this was just to understand how the exposure of one pathogen can confer immunity for the second pathogen, and the quick observation is that was high, strong cross-immunity can confer can reduce susceptibility to the second pathogen. I would like to discuss this much in the poster session. Thank you.
Okay. Yeah, I think you still have some time. So you have 1 minute, but I think, no, 1 minute, but okay. I think then maybe then we go already forward to the next presentation, and it's about epidemiologic modeling with multiple virus variants, presented by Marvin Schulte. Okay, so.
Hi, I'm Marvin from Fraunhofer ITWM, and during our studies we observed that newly emerging variants seem to be the major driving force for new infection waves, and that's why we asked ourselves, how can we model the effects of multiple variants? What is the long-term behavior of it? And can we actually improve forecast quality with such models? So if you want to find answers to these questions, come to my poster and talk to me.
Okay, thank you very much. So you are all very good in time. You don't even need the 1 minute. Make it even faster. Very good. So now we come already to the fourth presentation. It's about dynamics of contact behavior by self-reported COVID-19 vaccination and infection status during the COVID-19 pandemic in Germany, an analysis of 2 large population-based studies. And Antonia, maybe the presenter.
If I repeat the title, we won't have time for the rest. So we just looked at contact behavior and whether that varied based on self-reported vaccination or infection status in Germany. To answer this, we used data from 2 large population-based studies in Germany during 2021, the MOSPUT study and the COVIMOD study. In the bottom left-hand corner, we kind of see one of our forest plots. We ran negative binomial regression models and then looked at incidence rate ratios for the contact rates. If we look at the very bottom row of that, we see the fully vaccinated individuals, and for their non-household contacts, we see that they had more contacts than not vaccinated individuals. And we think that it would be important to include behavioral effects like this when predicting the effect of vaccination strategies on the burden of disease, since there do seem to be differences in contact behavior based on vaccination status. Find out more later.
Okay, thank you very much. Then, yeah, very good. And so now we come already to the fifth presentation. And it's about public behavior and pandemics, results of a representative online survey. And it will be presented by Peter Winsheimer.
Yeah, thank you very much. My name is Peter Winsheimer. I'm from the Disaster Research Unit of the Freie Universität Berlin. And we looked as part of the SEMSI project from a social science perspective in factors influencing the behavior of the public during pandemics and how they perceive model results. And we present our results of a public survey of the representative German population and our design for an online experiment to investigate how people react to models and how they perceive them and how different versions of presenting them influences their behavior and reaction to them. Thank you very much, and more at my poster.
Okay, thank you very much. Yeah. So now, already the sixth presentation, and it's about refining ICU capacity models, the imperative of advanced approaches for peak load predictions, and presented by Yunus Müller.
Hello everybody, I'm Yunus Müller from the JRC Combine in Aachen. One reason why we did all of the modeling and all of the NPIs during the pandemic was to keep our ICU stations and ECMO stations from overflowing. We did much of the modeling using compartment models like SER models and SEIR models, but we could find now that these models systematically underestimate, especially in peak loads, the needs and occupancy on ICU stations. So if you are interested in why that is, come to my poster later. Thank you.
Yeah, thank you very much. Yeah, and now the seventh pitch presented by Jens Fiedel, and it's about the role of social media-based sampling in epidemiological modeling.
Thank you. Okay, so it's the pandemic. You're on Twitter. You have a question about COVID spread. So you post a Twitter poll. You're somewhat surprised about the results of your Twitter poll, and the Cosmos survey is inspired by a question. It asks it itself, and it has similar results, so you're even more surprised. And now you're a little intrigued about, well, how far can we push social media sampling for our modeling? So our project is basically about this question. We do some social media sampling, we get some novel data out of it, and we compare it to the high-quality MUSPAT sample to see how biased our sample is. And then we fuel our models with it and want to see what our results are. And the overall goal is to approximate the window of usability where the speed of social media sampling trumps quality, for example, and test the application, for example, for tracking wastewater levels. My name is Jens Fiedel. I'm from Viola Prieseman's group, and come to my poster.
Yeah, thank you very much. Okay, now the eighth presentation. It's a systematic review on contact behavior and contact patterns in the context of disease transmission within European Union and European Free Trade Association countries, presented by Antonia Isabel Dreyer.
Social contact data is essential for modeling infection disease transmission. We are conducting a scoping review to present the existing literature on social contact data in EU and EFTA countries. Our aim is to map the available data and make it accessible to modelers. We searched 5 databases and screened 4,400 papers Due to the large number of relevant papers, we divided them into studies on sexual and non-sexual contacts. Here we present the first analysis for Germany and its neighboring countries, which resulted in 54 studies included in the review. The distribution of available data for the countries can be seen on the map. On the right, you can see a preview of the planned mapping. The map data will serve as a basis for future analyses, and it will help to identify gaps for future research.
Okay, thank you very much. So now we come to the ninth presentation. Again, with a very long title. I hope I can do it under 1 minute. And it's the next presentation is about the understanding changes in diagnostic stages, treatment outcomes, and healthcare use in persons with cancer or cardiovascular diseases during the COVID-19 pandemic. A review of reviews to support modeling of non-pharmaceutical interventions, presented by Nina.
Hello. We conducted an umbrella review about the changes in diagnostic stages and treatment outcomes and healthcare use in persons with cancer or cardiovascular diseases during the COVID-19 pandemic. We searched electronic databases, and after removing duplicates, title and abstract screening, and full-text screening, we currently include 66 studies in the review. Of the 66 studies, 33 relate to cardiovascular diseases and 33 to cancer. One study was related to both diseases. So our next steps are extraction and quality assessment of the included studies and systematic reviews in the German context to complement the existing international evidence and to support the German-based model in optimization.
Thank you very much. Now to the 10th presentation, and it's about causal modeling of disease outcomes, and there's independent predictors for the COVID-19 pandemic in Germany, presented by Andrzej Jarinowski.
So we attempt to model a moreover biweekly time series of multiple variables related to COVID-19 during pre-Omicron times. And we, first of all, look at the epidemiological indexes like R0, TA prevalence, etc., and contact patterns from different sources, the surveys and the GPS mobile phone data, and mobility patterns, as well as media interest and risk perception. So what we found that the GPS contact data from NetCheck is the best predictor for the future state of the pandemic, for instance, future R0. But on the other side, we've seen a clear association between mobility patterns from Google, from Facebook, and also the risk perception with previous or current epidemiological indexes. So it means if you want to model the future spread, you should use contacts. But if you want to predict the perception of the society, you should look at the previous epidemiological outcomes.
Thank you very much. So now to the 11th presentations, and now we start with a block of presentations about pneumococcal disease, which of course I welcome very much because that's also my field of expertise. And the next presentation is about the impact of non-pharmaceutical interventions on the burden of pneumococcal infections during and after the pandemic, and it's presented by Prerika Nera.
Thank you so much. So my name is Prerika, and here, during the COVID pandemic, we saw that the pneumococcal disease numbers went really low when compared to the numbers before the pandemic. But another study showed that the carriage prevalence rates were the same before and after the pandemic. So in the poster, we explain what could be the possible mechanisms to explain this decrease in numbers. Thank you.
Okay, yeah. Thank you very much. And as promised, we continue with pneumococcal disease. And this presentation is about the impact of demographic developments on the future burden of pneumococcal diseases, an integrated probabilistic differential equation approach presented by Maika Sarayan.
Hello, my name is Maika. So major pneumococcal diseases include invasive pneumococcal diseases and community-acquired pneumonia. While pneumococcal conjugate vaccines are effective, Germany faces challenges due to unique demographic transitions, including an aging population, international migration, and a regional population decline. So how do these demographic developments affect the future burden of pneumococcal diseases? We address this by integrating a population forecast model with a transmission dynamic model. So if you'd like to know more about this study, come by and see me at my poster. Thank you.
Thank you very much. And now we come to the 13th pitch, and it's about dynamic modeling of infant pneumococcal vaccination, a comparative evaluation of PCV13 and PCV15, presented by Kakashan Marine.
Hi, this is Kakashan, and I want to highlight a serious health issue, Streptococcus pneumonia, the major cause of morbidity and mortality worldwide. But thanks to pneumococcal conjugate vaccines, since its availability, many countries have implemented childhood vaccination programs, including Germany. And as a result, disease burden has reduced not only in vaccinated children, but also in non-vaccinated population because of herd immunity. So with each advancement in vaccination programs, we aim to reduce the burden of disease. So please join me at my poster presentation. That's like a comparative analysis of infant pneumococcal vaccinations using dynamic transmission model. Thank you.
Thank you very much. And I think now we come to the 14th presentation, and it's about the puzzle of pathogenicity, interpreting SARS-CoV-2 trends in incomplete data scenarios, presented by Micha Landol.
Hello. As you might tell, I'm not Micha Landol. He is still in the ICE train. He not only faced a police Einsatz, but also a fire in another train. So quite interesting. I hope he will make it here in one piece without being burned. And he is better than me in doing slides. Okay, I have to double freestyle it. Give me a second to collect myself. So in my last presentation, no, it was no presentation. After some years, the COVID pandemic entered the endemic stage, and during this, the data availability got really worse. We don't have good incidence data anymore, and many hospitals stopped giving data to us. And so now we have to, you all know this situation, now we have to get some tools how we can move on and see changes in the behavior of a pandemic. And for this, we are looking at data which was available the whole time and is still available, which is from the DIVI, Intensivbettengesellschaft, who publishes data about how many intensive care units, intensive care beds are occupied very reliably during the whole pandemic. We try to harvest this data about occupancy in ICUs. And so we used some machine learning and clever transformation into latent spaces to find out when the pathogeneity changes and the pandemic behavior changes. And my colleague Micha Landol will present this to you on his poster session. Be welcome. Thank you.
Thank you very much, and very sorry, but as I said before, we believe in our young scientists and we want to make it extra difficult for them, so really sorry. Now my question to the technique, do we have a 15th floor in our building or not? Okay, we don't have a 15th floor, so we stop here probably because there were also some problems with the strikes. So yeah, thank you very much to all presenters, and to all senior scientists, please take our young researchers as an example how to make your point in a very short amount of time. Thank you very much. So we are very good in time. I think the next point in the program would be the lunch break, and I hope that nobody is upset if we start the lunch break a little bit earlier. I think we had a very interesting morning, and I could use a break too now.
Okay, I would ask you to please take a seat, that we can get started with the next session. I would like to welcome you to this afternoon session. My name is Jan Hasenauer, and I'm very happy to be able to chair this session. Now, we have in total 6 speakers and only 1 hour time. So we have in total 10 minutes per presentation, 7 minutes for the talk and 3 minutes for questions. Just to prepare the speakers, I will sit down there. After 6 minutes, I will stand up. After 7 minutes, I will walk over here, basically, and in 8 minutes, I will stand in front of you, basically. So please be prepared and stay in time. There were questions, what happens afterwards if they continue speaking. I will not share what I said to some of the speakers. Yeah, but it might get some YouTube likes. I would suggest that we directly get started with our first presenter, which is Kai Nagel, an expert for mobility, and he will tell us some updates on agent-based models and how to include immune response. Thank you.
All right, good afternoon. Thank you for being here. So this is also an elevator talk. It's just a longer elevator, I guess. So there's a title of the talk. This is also in the book of abstracts. There's a paper which is underneath, which has the same title. So if you ever want to look up the paper, this is the way you can find it. This is essentially about immunity modeling. And the problem we had is kind of stated there. We have an agent-based model where we have, I don't know, a population of Berlin or Cologne, and some of them get infected, and then they pass on the infection if people meet and stuff like that. And by doing that, the disease is actually able to spread through the model. And if we reduce where people meet, then the spreading is delayed and eventually it might die down. And one thing you need is the infection model. And the infection model that we use is a dose response model, which essentially says if there are people in this room here who shed virus, it goes into the air. This leads to a concentration in the air. This is inhaled by me. If I do this for longer, it's a higher dose. If I do it for shorter, it's a smaller dose. If I wear a mask, it's a smaller dose, stuff like that. And then you have an infection model, which is this equation here that I can probably point out. This here, where the probability to get infected in this situation is this kind of equation. Now, in this case, I don't know how well you still remember Taylor expansion, but the exponential is Taylor expanded to 1 plus x. So if x is not very large, this is what you get. And then you have 1 minus 1, essentially minus x, but x is this. So the linear term of this is just that here. And this essentially says if you inhale twice the doses, your probability to get infected is twice as large. So a lot of this stuff is essentially proportional. Now, this is a probability. A probability can't become larger than 1, so this needs to saturate at some point. And so this is what this model does, is eventually if your doses is very high, you have e to the minus infinity, which is 0, and so your probability to get infected is 1. So this is what this model does. Now, we can actually plot it. This is 3 different ways to plot the model. They're all quite interesting, but we don't have time for this. So next slide. What we had the problem in modeling during COVID is that the immunization histories got increasingly complex. So here's an example, is a person who had a wild-type infection of day 50. The model starts sometimes, I don't know, middle of February or something, maybe an mRNA vaccination on day 200 and a Delta infection on day 600. And now what we want to know is how immune is this person against Omicron after that Delta infection. And you have to imagine that there's all these different combinations here. So people might have originally an Alpha infection. They might have gotten an Astra vaccination. They might only have had two immunizations or 4. The time distances between these things might actually be different. So you have all these combinatorial combinations of trajectories, and we needed a model for that. And so, I mean, there's not enough time to explain how we came up with that, but we have a model that has 2 steps, which actually comes in part from the literature. And so the first part is that we assume antibody levels, which are quite normal. So the way you read this, you have an immunization, you have an antibody level, you can measure this. And so the person gets the initial wild-type infection, and then it has an antibody level, and then this is exponentially decaying. And then you get another immunity event, and the antibody levels go up again, and then they are exponentially decaying, and you get a third immunization event, and they are decaying. So it's this kind of thing. And what is important is we have different antibody levels against each virus strain. Yeah? So you have the wild type infection, and then you have antibody levels against the wild type, against Delta, and against Omicron. Against Omicron is not a lot. Yeah, blah, blah. Maybe the most interesting one is this here. You have a Delta infection, and in this case, the Delta antibody level is suddenly higher than the wild type antibody level. Yeah? So it depends on your infection type. So you have these antibody levels for each possible strain that can potentially happen. And I will tell in a minute how we get there. Now, the second part is once you have the antibody levels, how do you come up with how do you correct the infection probability? And after some trying around, what we did is we divided by this term here. So this is, if your antibody level is 0, this is just 1. It's the same model as before. But let's assume the beta is 1 and the n is also 1, then this is 1 plus 1 is 2. And then you need twice the doses to end up at the same infection probability as before. Yeah? So immunization is just a divider for the doses. This is even if you're vaccinated, if the doses is high enough, then you get infected anyway. So this is how we put it in. There's also kind of some reasons why this actually makes sense. And yeah, so I already explained that. This is calibration. I don't know, he's not yet standing there, so I can maybe say 2 words about that. There's these studies where you have days since vaccination, and then it has the vaccine effectiveness is the red points that were collected. And then you have like these different ones. This is certain people vaccinated with the wild type, with the original vaccination, but then the immunity against Omicron. And in blue is then against Delta, and in green is against the wild type, and then people get a booster, so it goes up. So you have all of these data points, and what we use is we use this type of model, so you can calculate the vaccine effectiveness from this thing here, which is this equation, which comes out of this, which then is a function of the beta term that you need to evaluate. You need to know these initial antibody levels that you get from the vaccination, then there is a half-life type of the exponential decay, and then you need to have kind of this jump if you get a refresher immunization. So he's standing up, so I need to move forward a little quicker. So you start having these histories where then this is the antibody levels and this is the resulting immunity, and you see kind of there's a person has a Delta infection, then has a very high immunity against Delta, but also some immunity against Omicron, which is, however, lower. Now the question is, how can you calibrate this against new virus types, and what comes to the rescue? In this case, there's these neutralization titers, so they do something like this where they say, okay, your existing immunity is this, let's say this here, your new immunity is this, is a factor of 22 lower. So essentially you can say people have an antibody level of some level against Delta, you divide this by 20, and then you have the antibody level against Omicron, and then you can just convert this for everybody you have in your simulation, and then you can keep going. And this is the conclusion, which concludes everything I've said. So you have an antibody level against each virus strain. You have all of these immunity events which refresh this, otherwise you have decay. I have the division there, and then I have that you initialize from virus strains. Thanks.
Thank you very much. And also thank you for staying perfectly in time. So we have time for questions.
Yeah, thank you very much for the interesting talk. You now have presented the waning immunity. Have you already thought about different types of waning against any infection and against severe infection?
Now I can make a long answer. We have essentially a T-cell immunity which is different from that which is for protection against severe diseases, and I don't have enough time to explain this in more detail, but essentially we assume the highest immunity you have ever reached is kind of memorized by the T-cells.
Okay.
Against severe infection, but not against infection.
Yeah, okay, thank you.
More questions? Okay, I would like to ask about the calibration. So, okay. Because we still have time. About the calibration part, basically. What did you use there precisely for calibration? Did you mostly base it directly on observed quantities for the individual parameters, or did you also do solving some inverse problems, basically based on the course of infection and individual, respectively, the population underwent?
No, this was all these registry studies, these large vaccination efficiency studies that we used.
Okay, thank you. Is there one more question? If not, then thanks a lot for the presentation. So this was really great, making up for some of the time I spoke in the beginning. So we continue directly with the next speaker, which is Elizabeth Goulot. Gold. Okay, thank you very much. From the Max Planck Institute for Infection Biology. And we will hear in the following about the optimal age for infant measles vaccination. So I'm very much looking forward to that. Thank you.
Excellent, thank you. I don't know how this works. Okay, we'll do it without it. Yeah, so measles vaccination. So it's a short talk, so I'm going to start with what I hope you get out of it, which is these take-home messages. So the first one is that measles vaccine effectiveness is going to be age-dependent, where I mean that the older the child is when they get vaccinated, the more likely that vaccine is to protect them against measles infection. This leads to the second point, which is that vaccine age is going to affect measles incidence on a population level, and that this age can be optimized to minimize the incidence. And the final point that I want you to understand is that the optimal age is going to depend on the population we're vaccinating. So by this I mean the social contact structure of the population, the amount of transmission, the amount of vaccination. And to kind of summarize the results from all of those factors, the more transmission there is in the population, the younger the optimal age is going to be. So, now to actually show you that this is true. Oh, this is missing some lines. Okay, so this is data from a systematic review of vaccine effectiveness estimates with different vaccination age. And what you should be able to see here is some lines of a shape-constrained additive model fitting through the data. But you can't, so pretend, please. Yeah, so we should fit a model to this data. And what this shows is kind of what the data is showing as well, is that the vaccine effectiveness is lower at around 6 months, and it increases as the child ages. And it starts to saturate around 18 to 20 months. So what we can do with that line that you didn't just see is we can invert this, and this will give us a risk of infection with measles due to vaccine failure of the child throughout that child's life. And this is going to decrease with age of vaccination. However, there's also a risk coupled to this, which is a risk of catching measles before being vaccinated. The longer we wait to vaccinate the child, the more time that child has to go out and get measles, be infected with measles. And we can combine those to give us the overall risk of measles infection throughout the child's lifetime. And then we can use these risks and we can translate them using a transmission model to give us the population level incidence at different vaccination ages. And what we find, and what I will show with data later, hopefully, is that this is going to change as the vaccination age changes. And by identifying the minimum incidence, we can identify the optimal age to vaccinate. So good, we've got a method for calculating the optimal age. We take a model, we simulate incidence, and we identify the minimum age. But the model is going to have to take into account some kind of variation in these risks. So this risk of catching measles prior to vaccination is going to depend on multiple factors of the population. It's going to depend on the mean age of infection, whether or not that's before or after the vaccination age, which itself is going to depend on transmission parameters such as R0 and the social contact structure, alongside the vaccine coverage. And this green curve is also going to depend on the vaccine effectiveness curve that you didn't see, and vaccination delay distributions. So, there's no data. Okay, so there's some lines which should be here. They're not. This is quite challenging. Okay, these lines are showing exactly what I just said. We parameterize the model for the Chinese social contact matrix. And what it shows is that vaccination age is changing sorry, the incidence is changing with vaccination age. I have a link to the preprint later. You can look it up if you want. And these dashed lines are showing when the WHO recommends. And if you look at the other social contact matrices, it should show the same thing. So what it will show is that the transmission level is going to change. As the transmission level increases, the vaccination age is going to decrease. And this is going to be different between different social contact matrices, hopefully. With South Africa tending to have the lowest the lowest optimal age, whereas China tends to have the highest optimal age. Okay, fingers crossed for this one. Oh, there's nothing. Okay, well, what this is meant to be showing is that the optimal is just showing the same thing, but for the optimal, only for the optimal ages, for different vaccine coverages. And what you see is the same thing. So as the transmission rate level increases, the vaccination age optimal vaccination age is going to decrease. And also, as the vaccination coverage increases, the overall amount of transmission is going to decrease. And thus, the optimal vaccination age is going to increase. And I hope you believe me, because there's nothing here. Okay, to summarize the data you haven't seen. Measles vaccine effectiveness is age-dependent. And as a consequence of this, the vaccination age is going to affect measles incidence and can be optimized to minimize this incidence. We developed a method to calculate the optimal age. And what is important to note is that this method could be applied to other vaccine-preventable diseases, which have this relationship between vaccine effectiveness and age. The optimal age is dependent on the population. I hope you believe me. With the more transmission corresponding to a younger optimal age. And there's a high level of heterogeneity in the optimal ages we identified, indicating potentially the current schedules could be recommended, could be expanded. So, thank you for listening. I'm sorry about the plots. Don't know what happened there. And if you're interested, there is a preprint where the plots should be fully rendered properly. Any questions, please?
Yeah, thank you very much, and very sorry. I would have loved to see the plots, but yeah, thanks a lot for providing the QR code. So we go into questions.
Thank you. I was just wondering, is there also an age dependency on side effects of vaccination, so that there might be a different optimal age because of that?
That's a really interesting question. Not as far as I know. I've not seen anything about it, and in the papers I've seen, they haven't mentioned it. So no, not as far as I know.
Okay, thank you.
So we have a next question. Maybe you could hand over.
Thank you. Maybe I missed it, but there is also maternal protection from antibodies from the mother going through the placenta, and I haven't seen that in your model because it might be worthwhile vaccinating the mother again during pregnancy to get higher titers and then have a longer protection and then vaccinate the child a little bit later.
So that's definitely an option for some vaccines, and it is maternal vaccination is definitely used for some of these. For measles, it's a live attenuated vaccine. I am not sure, so it's not really suitable for that kind of thing. I don't know of any specific problems between measles and maternal pregnancy damage, so I can't really speak to it. But I do know that it's not really an option because of that. Maternal antibodies are included in our model. I didn't show the model. I don't think it would have shown up at this point. But yeah, it does play into it. Yes, but it does interfere with the vaccination. Yeah, so that's where the relationship between vaccine effectiveness and age comes from, along with the maturity of the immune system.
Yeah, thank you a lot for the very nice presentation. Also, some things were not visible. I'm not sure what I'm asking would have been visible. So one very critical component seems to be the contact structure, of course, and probably also contact structure in the very, very young, which is extremely difficult to measure. So how did you approach that using the available contact surveys from the different countries? And yeah.
Let's see if this comes up. Okay. Oh, there's some color. So we did include different contact structure. So we use the mystery, it's a mystery, contact matrices, which have available a yearly estimate, a yearly age group estimate for these things, and then we just assume constant constant contact rate between those. It is a limitation. We have kind of expanded that to try and use some other ones, because a limitation of the mystery is that it doesn't really cover some of the regions we're really interested, so sub-Saharan Africa, for example, or Saharan Africa. So, but yes, yeah. I hope that answers your question.
Okay, thank you very much, and let's thank the speaker again. And then we directly continue with our third presentation, which will be delivered by Beryl Musundi, and will cover the topic of within host and between host dynamics, and we will see results on a multi-scale model.
Okay, so in this presentation, I will show you some of the approaches that have been used to link the dynamics of diseases at the different scales, and also illustrate how we did this for a cholera infection. So we know models have been used to understand the spread of diseases, and most standard models restrict the dynamics to one scale, that is either the within-host scale, where the focus is usually on the pathogen evolution within an individual, or the between-host scale, where the focus is now on the transmission in the population. However, there are models that are coming up that link these two scales and also provide novel insights into the disease transmission process. So what approaches have been used to link these dynamics? There are several, at least for deterministic kind of models. So I'll just illustrate some of them. And the first approach is linking through nesting principles. And in this case, you develop your within-host model, think of what between-host model you want to use, and then link the two, either using a parameter or a structural variable. So in case of a structural variable, your model, the between-host model that you use, has to be structured according to the time since infection. So your infected population does not only depend on the time, but the time that has passed since the person got infected, such that when you go to the within-host dynamics, the changes in the pathogen density also depend on this age of infection. And then the link between the two is making the transmission rate and maybe things like the mortality rate also depend on this age since infection. The second approach is mostly for diseases which have an environmental compartment or contamination from the environment. And in this case, the disease transmission process is divided into three time processes. You have the first time scale, which represents the individual dynamics. You have the population dynamics occurring at an intermediate time scale, and you have the pathogen evolution occurring at a slow time scale. And this environment is the one that provides a functional link. So environmental contamination will provide the functional link between the individual and the population dynamics. The other approach is to link through network modeling principles, where you have an individual with unique within-host characteristics, and this individual is placed in a network of surrounding individuals. And the last approach, which I'll also illustrate how we use this, is to link the between-host or the within-host model through developing an within-host inspired between-host model. So in this case, it's kind of similar to the nesting principle, but in this case, you use physiological variables of the within-host model, so things like genetic variations or immune response to develop your between-host model. So we did this for cholera, so we developed this immunoepidemiological model, and our aim was to first formulate the model and also understand how we analyze such kinds of model. So for our within-host system, we just considered how the pathogen interacted with the immune response, and from this, we could now be able to describe the immunity changes of uninfected individuals according to this function, G of W, so such that an infected individual, we knew when the time when infection started, so the immunity status at the time of infection, which was 0, and at the point where recovery took place, which was W0. So now that we knew the immunity changes of each of one infected individual, we could scale it up, we could scale it up to the population such that the entire infected population is structured according to this immunity changes, which we just refer to as the immunity status. So the total population, infected population, is a sum of all the individuals with the different immunity statuses. And for the between-host model, because cholera is also an environmental-driven disease, we considered that not only an SIR model, but also considered the environment as an additional, like adding additional an additional component in the transmission process. So I won't go much into that. And of course, we formulated some model equations to represent that. And of course, for our infected compartment, because now it did not only depend on the time, but also on this immune response, it was a partial differential equations, while the others are just ODEs, which represent the differences or the changes with time. So we did the analysis of this. I won't go into the analysis, but what new thing that we found is in terms of the reproduction number, it does not only include like the inter-individual dynamics, but also the intra-individual dynamics. So you have, you have also components of the immune host system in this between host model. So in conclusion, we found that, of course, multi-scale models provide novel insights into disease transmission process, but there's a lot that can still be done, including the use of data and other things, I think. So if you want to read more about what we did in the mathematical analysis, you can read our paper, and the other papers also have more information on multi-scale modeling of infectious diseases. Thank you.
Yeah, thank you very much for this nice presentation. Are there questions to it? Maybe I can briefly get started while the others warm up. So with the theoretical result you obtained for this model structure, how much does that depend on the precise topology and the precise processes within the host, basically? So are there factors which play a larger role than other factors, basically, of within host dynamics? So, I mean, you had various parameters in the model, basically, and I was just wondering, the theoretical results, in particular the reproduction number, there were some parameters to which this reproduction number is more sensitive compared to others, basically.
So we didn't do a sensitivity analysis yet, but that's something that we can also maybe do, of how much influence these within-host parameters will be on the between-host dynamics. But of course, from the reproduction number, you can already see something like this growth in the immune response already would have a greater effect on the reproduction number. Yeah.
Okay, thank you. Are there further questions? Yeah.
Usually, if there are two scales which interact, then on the large scale, you usually can represent the short-term behavior by a few parameters, which, a few effective parameters, which can be seen on the large scale. And maybe you don't need the full curve or so, but only some moments of that. Is that true, that you can reduce it to come from the small time to the long, that some few parameters are enough for that?
Yeah, we can also do that, and probably an approach would also to make the within-host model like be at a higher, like a fast time scale, and then we put it at equilibrium so that there are not so many, so we can analyze the system by just using few parameters.
Thank you for a very nice talk. Did you consider any like stochastic versions of this?
So for this model, we did not consider stochastic variations, but we have another model that we also did, which we considered some stochastic variations, for the within-host model at least. Yeah.
Okay, thank you very much for this very nice presentation and also for the questions. So we directly continue with the next presentation, which will be delivered by Martin Kühn from the Deutsche Luft- und Raumfahrtzentrum in Cologne, and he is also co-affiliated at the University of Bonn. And we will hear about hybrid modeling approaches and how they can actually contribute to reduction in energy consumption and therefore also to more green analysis in various ways. Thanks.
Okay, yeah, thank you very much for the nice introduction. I'm going to present today about hybrid models, and this is joint work with Julia Bicker and René Schmieding. But first, before coming to hybrid models, let's look why and why not we would use agent-based modeling. So in agent-based modeling, we really model individual agents or persons. And of course, this is an advantage because an infectious disease transmission happens on the individual scale. So this is just a natural implementation of human contact pattern behavior, and it allows explicit answers to, for example, household transmission. So if I want to model or answer the question, so what's the transmission on households? Of course, there is a lot of parameters to be defined, but it is difficult to do this with equation-based models. And of course, yeah, I don't know if one would implement an agent-based model deterministically, but it would then include stochastic effects. With these agent-based models, we can do a lot of nice stuff on the supercomputer, and there is a very nice talk by David Kerkman tomorrow, where he, for example, shows that we can compute a city like Halle or Braunschweig for a time step in Halle or Braunschweig in less than a second. But still, if you want to do a lot of runs, a lot of different scenarios, the stochasticity and the computational complexity of the agents means that we need a lot of energy, that we need a lot of computing power. So our idea is to go to hybrid modeling, but the question is, what is actually hybrid modeling? Hybrid modeling could be a lot, and how I would like to define hybrid model is to take the best of the two worlds of equation-based modeling and agent-based modeling, and we include the complexity where necessary, and we reduce the complexity where possible. There are two approaches. So one is what we call spatial hybridization. We have some focus region. So in the left upper corner, there's some focus region where we would, for example, have an agent-based model, and then we have connected region with an influx from, for example, equation-based models. There is temporal hybridization, where at some point of the epidemic or endemic, pandemic, we have some agent-based model. At some point, we change to an equation-based model, and then we change maybe back to an agent-based model. And where is actually, or where do we see the application here? So the spatial hybridization is, if we want to have detailed results in a focus region, because political decision makers are asking us what's the development in, for example, Munich, Berlin, Cologne. But we cannot neglect the influx from surrounding regions. For temporal hybridization, for example, we can say if incidence numbers are very, very high, stochastic effects do not play such a crucial role that at some point we might change to metapopulation models to just reduce the computational effort. Then I would like to come how to realize hybrid modeling, and to take a little bit the broader look, Julia Fitzner said this this morning, that the variety of models is very important. And we do this with the scenario modeling in MONID, but we also do this internally, that in our software framework, we have many different models that we try to give them the same, a similar structure as much as possible, so that they have the same flexibility in parameters, etc. So if we want just to have a different stratification in age groups, or that if we want to just use income as another dimension, it just only should take like 5 to 10 lines to change this and not rewriting a completely different model. And if we have set up this, of course, then this is the first step to combine these models. So we have different models, but basically we just change maybe the transmission and not the mobility process. And for the agent-based model, of course, high-performance computing is very important, but this is something that I will leave to David's talk tomorrow, which I can highly advertise. I wanted to show some results for a spatial hybrid epidemiological model, and therefore I would like to come, how do we exchange individuals? Let's say we have here this focus region, we have some connected regions, and then, of course, from the agent-based model to the meta-population model, it's very simple, we can use a projection. Between these equation-based models, there are a lot of opportunity or a lot of possibilities. Still, one could propose different approaches, but the question, the most important question is how can we get back from the coarser level to the finer level? Yeah, okay, so projections. For equation-based models, there are a lot of different works. Still, there's space for improvement maybe, or for new ideas. But the question from EBM to ABM is, first of all, model dependent. Here we are sampling uniform in the region, but generally the question is how much information do we need or want to retain to go back the scale. And if we now consider this for Munich and for its neighboring regions, we take as a baseline version a full-scale ABM. Again, not for Munich, but again, I refer to David's talk. And then we put this against the spatial hybrid ABM-EBM, where we have just Munich here in the center as an as an agent-based model, and the surrounding regions are then modeled by meta-population models. The transmission model could be anything. Here it's some kind of this. And then just to show the results on the map, this is not very meaningful because the idea here is not to show the infection dynamics over a different time, but to show what's the gain of the hybrid model. And still, if we look at the different results from the agent-based model, I think it's difficult to see because from the back, because the lines are very thin. But with the parameters that are okay between the two of the models, we see that we have similar results in the different regions. But the main result I would like to present is here that with the agent-based model, we have, with the hybrid model, we can reduce the runtime by 96%, in this case for 70,000 agents. Of course, this is problem dependent, and normally the larger the number of agents, the more the gain. And we will not reduce the scaling of the ABM, but we can significantly reduce the runtime, and thus also, as a proxy, reduce the energy that we use. Okay, and that's actually all. Thank you for your attention. Short before Jan arrived here.
Yeah, thank you very much for the presentation. Are there questions?
I'm not entirely clear from your presentation how you, for the agent-based model, do you have the equation-based model as an environment and then use a Monte Carlo method to solve, or how do you interchange between...
How do we interchange between the equation-based model and the agent-based model?
Yeah, so is the equation-based model environment that your agent-based model sits in, and it's having some external input, and then you Monte Carlo solve inside that, or?
Actually, I would like to see this way, that we have some, so the left, the ODE-based model, and we have some agent-based model, and these are the local transmission models. And then we have a mobility model here in this context from the agent-based model to the equation-based model. We have a stochastic jump term, which is more or less jumping around some official registers data, but not the same every day. And from the equation-based model to the agent-based model, we have also some stochastic jumps that shift like a person, although you don't have a person in the equation-based model, shifts kind of a person to the equation-based model, sampling in the region uniformly. But yeah, there is still some improvement for how much information to retain to put the agent of which I lost the information back to the agent-based model.
Okay, we would have time for one short question. Sorry, could you pass over?
Hey, thank you. So this is for the spatial hybridization. For the time-dependent hybridization, do you also encounter the same issues when jumping between the two?
I think a general issue with with the temporal hybridization is still to determine the threshold when to change. And I would say this is still an open question to us when to switch from one model to the other, although Julia and René have already worked on this a little bit. But of course, it's surely also problem dependent, depends on the reproduction number, and on the general process, if it's diffusive or not.
Okay, thank you very much for your presentation. Then we continue with the fifth presentation, which will be delivered by Philipp Dönges from the Max Planck Institute for Dynamics and Self-Organization in Göttingen. And we will hear about here a multi-disease model, basically in particular the impact of coupling strength on the dynamics.
Thanks for this nice introduction. I will talk about how to build compartmental models, mean field approach, for multiple pathogens spreading at the same time and interacting. So why am I interested in that? Why do I want to do this? Because that's the reality we are faced with, right? Even concentrating on respiratory diseases, we have several which show these nice seasonal patterns, and they are interacting. Maybe the most dominant example is COVID, and the interventions introduced for COVID also suppressed waves for multiple diseases. Okay, I don't have a laser pointer. And then the lifting of the restrictions lead to these rebound waves due to excess susceptibility build up over the restriction time, and all this nice dynamics here. So I will differentiate between two different types of interactions. On the one hand, behavioral feedback. This is more the direction of info expand. So an indirect interaction, people reacting to the spread of one disease and then changing their contact behavior, and then also a more direct interference between diseases on a pathogen-pathogen level, for example, cross-immunity or opportunistic infections. So how do these models look like? The most classical approach would be to do something I would call a tensor product between two SIR models. So we have a disease A. We have a disease A spreading horizontally. So you start in susceptible and moving infected, recovered, and then also disease B vertically, and you have all these different compartments in between. So, for example, in the middle, the dark red I can't point on would be a co-infection compartment. Oh, okay. Then thanks. You have to leave it pressed a bit. How does it scale if we want to go for a detailed model? So typically, we want to have like a more realistic procession here with an e-compartment, maybe some quarantine, hospitalization, and so on. Then you include age groups, you include different types of immunity, vaccination. So you easily can have 50 compartments even for a single passenger model. So that's how well this approach scales. Now I can't, well, no. Maybe it's low on battery? I can't, yeah, great. So how does it scale? Well, back of an envelope calculation, for 50 compartments for diseases, with this formula you end up with something like 6 million compartments. This is more on the agent-based side, not really compartmental modeling anymore, so we need some approximation here. So instead of, on the left side, the cross product, the tensor product of the two models, we want to have like more of a separated spread of two diseases and then introduce the coupling as functions between them. This would, if it works, leave us with a more reasonable amount of compartments, but we have to do some assumptions. So for the coupling, because we no longer have like a co-infection compartment. Here the amount of co-infections is just this compartment, but we don't have it here. So we need to assume that these are statistically independent. So if we want to know how many co-infections we have, we assume that the fraction of this compartment here is co-infected, proportional to the amount of infections we have in this model. Well, this might be a bit theoretical here. Let's look at two different examples for coupling. So first, the behavioral feedback example. So let's assume the cases for both diseases get reported and reduce the infection rate for only one disease, disease A. So in a more visual way, we add up these two compartments, and this then inhibits the spread of disease A. The first thing you can clearly see, if we introduce this feedback, this reduces the wave, and if we make it strong, it even has this interesting effect of a rebound wave. The second thing you can see here is that both the full model and our approximation line up perfectly. And if you look at the number, at the actual numbers, everything you can find is numerics. So our seemingly approximation holds perfectly. Let's look at a different example. Some competition cooperation between the two pathogens. So we do it this way. We say, well, have you been prior infected with B? If yes, then the infection rate for disease A is multiplied by C. If no, then no change. So for a C larger than 1, this would mean cross-immunity. For C smaller than 1. If for C larger than 1, this means opportunistic infection, as an example. So as expected, hopefully, competition suppresses the wave, cooperation heighten it, but now you can see that the two models no longer line up perfectly. We can do a parameter scan, and you see that the error increases the farther away you get from 1. It's only 10% in this example, which is not that bad for a compartmental model. We have a lot of assumptions in there, but there's no guarantee for your specific model how large it will be, and it's something one should be aware of. So now we have seen two examples, one which worked perfectly and one which the approximation had some error. So what is the systematic behind it? Well, we find that the approximation is precise if the transition rates for disease A are independent of the exact disease state you are in regarding disease B and vice versa. So maybe more visually, if all these three transition rates are the same, and similarly the next three and these three and the three down here. So as examples, it works great for some only external forcings like seasonality or MPIs in your system, or behavioral feedback on the infection rate. You have to be careful if you have cross-immunity or opportunistic infections in. Yeah, all the work was implemented in a nice Python package some colleague of mine developed. if you want to start with compartmental modeling, maybe check it out. And with that, I want to thank you for your attention and the nice Recipe Now study group for their work and support.
Yeah, thank you very much for this nice presentation. Are there questions? If not, I take again the opportunity to ask for first question. So you have this general statement now, basically, that if the rates are essentially independent of the underlying disease state for the other process, basically, that this kind of is a good assumption, basically, for this approximation. Could you do something which is more higher order in some sense, like not do the zero order marginal approximation, but kind of extend to something which is in between the full model and the reduced model you presented, basically, to still capture some of the effects?
So basically your question is, in the case where it does not work perfectly, can we improve the approximation here? Yeah, we hope that this is possible, and we are looking into it. So the idea would be to have something like a Taylor expansion, right? Yeah, this is what we are working on.
Yeah, okay, thank you. Further questions? Okay, if this is not the case, then thanks a lot for your presentation. Then we come to the last presentation in the session, which will be delivered by Antonia Bartz from the University of Münster. And here we will hear first results of a scoping review regarding the reporting on mathematical models, I guess, how comprehensive information is in respective publications.
Thank you. Yes, so I will be presenting a little bit on guidelines on quality assessment and reporting of mathematical modeling studies, specifically for infectious disease dynamics. And this was done together with the MONID modeling working group. During the pandemic, we saw a lot that mathematical models are often used to help guide public policy decisions. And from some neighboring fields, we also know that reporting guidelines often help ensure that studies are comprehensively and transparently reported. In addition, we use quality assessment tools in order to help readers be able to assess the credibility of a study that they're looking at. However, to our knowledge, we were unaware of any widely accepted or used quality assessment tools or reporting guidelines specifically for infectious disease modeling studies. Therefore, in the study, what we did was we wanted to look whether there were any tools or guidelines specifically from infectious disease modeling studies or any adjacent fields of research. And once we had identified these tools and guidelines, checking what common themes or topics were mentioned. Just as a side note, this is very much a work in progress, so you will be seeing preliminary results, and we're working on updating them as we speak. In order to answer our question, we performed a scoping review where we first developed search strategies using Medline, Web of Science, medRxiv, and bioRxiv, and we worked together with an information specialist in order to ensure that we had a search strategy which was sufficiently sensitive but specific. If you're interested in more details on that, please come see me later. We used Covidence for our title abstract screening and full text review, whereby we included any reporting and best practice guidelines or quality assessment tools which were for dynamic models or decision analytic models. During this process, we also excluded any guidelines which were specifically for clinical course models and drug or treatment assessments. We also included any country-specific guidelines which we felt were not generalizable. In addition, we excluded literature reviews which didn't make any of their own conclusions or recommendations, but we will be checking these reviews for references to use in future articles, or looking at their references in order to see if there are any further guidelines that we've missed. In addition, we excluded any individual cost effectiveness or modeling studies. For the data extraction, we are extracting the recommendations for quality assessment or reporting and splitting these into 7 dimensions or topics and the respective subdimensions. I will first start by talking about the review that we're doing. So we have, overall, we've identified over 8,000 studies, of which we removed approximately 2,000 for duplicates, leaving us with just over 6,200 for the title abstract screening. We performed double screening and then resolved conflicts in our group. And in that process, we removed about 6,000 studies, leaving us with a total of 170 for full text screening. This is still now a work in progress. We're again double screening, and we'll be resolving conflicts by consensus in our group. And at the time when this presentation was submitted, we had double screened 15 of our publications of the 170, and 143 had been single screened. Prior to this, we also did a pilot study where we piloted 22 studies, or extracted data from 22 studies. So for the future, for the further steps here, I will be looking specifically at the results of those 22 piloted studies. So first, I'll bring your focus to the central part, which is kind of our legend. I mentioned previously that we identified 7 dimensions. Those are listed here. For applicability, we looked at the relation between a model and the research question that was being asked. Model structure referred to whether or not a model, for example, avoided unnecessary complexity. Parametrization and calibration looked at the parameter values and how they were extracted, for example, via literature, expert opinion, or calibration. Validity included things such as internal, external validity, uncertainty, for example, parameter uncertainty and structural uncertainty. For interpretation, we looked at the author's interpretation of the results and whether those were substantiated based on the given data. And for reproducibility, clarity, and transparency, we included things such as code availability. Now, for the plot on the left, we see the overall proportion of publications that mentioned a dimension, and on the right, we see this same plot, but split up by the individual studies we looked at. Again, these are the 22 piloted studies. These results will be changing over the course of the next few weeks and months. Any publication was considered to have mentioned a dimension if any of the subsequent subdimensions for that dimension were mentioned. So if we look specifically here, we can see, for example, that applicability was mentioned by all of our studies, whereas interpretation was only mentioned by 5 of the 22 studies. If we look at this across the studies instead of across the dimensions, we can see that some studies mentioned all 6 of the dimensions, whereas some only mentioned 3 or 4. We then did this for all of the subdimensions. So first I'll draw your attention to the table on the left. There we just have, again, listed our dimensions and the subsequent subdimensions that fall into each of those categories, written horizontally so it's a little bit easier to see than the x-axis, which contains exactly the same information. Here we again see that some subdimensions are very frequently mentioned. So this was, for example, things such as study design, parameters, and parameter uncertainty, while others were mentioned less frequently. So these were things like publication details or parsimony. This looks maybe like a little bit much at first, but here essentially we did the same thing as before, where we took the same bar plot we just had, but then split it up by the different studies that we looked at. So here again, if we look at the rows, we can highlight some rows, and here we see that in some studies, almost all of the subdimensions, so in this case 23 or 24 subdimensions, were mentioned by a single publication, whereas other publications only looked at 5 or 6 of the subdimensions. Overall, we saw that there's a lot of heterogeneity in the themes or dimensions and subdimensions that were covered by the existing recommendations that look at reporting and quality assessment for modeling studies in general. To our knowledge, still, there are no widely used tools or guidelines which are specific to infectious disease modeling studies as a whole, although there are some which are slightly more niche and focus on a specific infectious disease or specific aspect of an infectious disease. Our next steps will be to adapt the dimensions and subdimensions that we've identified here in order to create our own quality assessment tool and a reporting guideline for infectious disease studies. And we will be looking for feedback on these developed tools and guidelines in the coming months, since you will be the ones who hopefully will also be using these when publishing studies. So with that, I would like to thank you for listening, and if you'd like to become involved in this process, please reach out, and we'd love to have you help us with this.
Yeah, thank you very much for this nice presentation. I take the opportunity of the first question. Sorry, Martin. I was very puzzled with only 20% mentioning interpretation, basically. Do you have an explanation for this?
An explanation, no. For interpretation, you mean the dimension, right?
Exactly, yeah.
Yeah, so that dimension actually only included one subdimension, so it was a single item, whereas some of the other dimensions had several aspects which contributed to that dimension. So in one sense, it is more difficult, I guess, for a guideline to mention that, since there's less things that will lead to that dimension. Other than that, I think we do have data on the specific things each guideline mentions, so maybe that's something we can look further into to see what the details are that were mentioned there.
Okay, thank you.
Yeah, thank you very much for the nice presentation. Maybe I missed it, but how did you come up with the different subdimensions? Was this your decision, or after looking at the 170 publications?
So the subdimensions were actually essentially how we extracted data initially, and then we used the subdimensions to create our dimensions. But so for the subdimensions, we kind of started with 2 guidelines which we were aware of from adjacent fields. And we looked at those and we first saw, okay, what are the kind of things that are mentioned in these guidelines and tools? And then we extracted those, and then as we extracted further through these 22 piloted studies, we then added additional subdimensions as we saw fit, and then at the end we kind of looked, okay, what are the general themes we're seeing here, and then classified the subdimensions together into the bigger dimensions.
Okay, thank you very much.
Sorry, I have a very critical question. The people I know who do things which are really important and bring progress are typically people who do not are not experts in formalism. And you propose here that you have to be part of all these formal facts. You must apply. You must satisfy all these formal facts, and then you will be proposed by your finder. Then you propose this one goes to all of these formal things. And I guess this is not really the thing we need for finding papers which bring something new or which are excellent. So I think it's almost orthogonal to that. This is a very critical standpoint now, but I must do it in this hard words to start the discussion, let's say.
So I didn't fully understand everything, but from what I gathered, I think you were, correct me if I'm wrong, I think that, so looking at all of these subdimensions and then saying that you needed to, if we say that you need to have all of them, then that could be kind of restrictive in terms of not all newly published research will have what you're saying. Sorry, with the audio of the microphone, it's a bit hard to hear up here. Yes, that's actually better. Yes, I would agree that that's true. So one thing, maybe a limitation for us, is that we can't necessarily argue that just because something fulfills all of these criteria, or that it's good, or that something should fulfill all of these criteria. For now, we're just looking at what criteria are commonly mentioned in guidelines, and then we create our own, maybe take that into consideration, because also some things that we've seen are that some guidelines are really specific to, for example, sensitivity analysis, and so then those won't have recommendations across all dimensions. So that's something that we also want to consider. And then also, once we have the guidelines or recommendations, recognizing what maybe the limitations are and when one should use certain elements and when other elements can be ignored.
Okay, thank you very much. And I would like to thank the last speaker, first of all. And then obviously also all speakers, again, of the whole session, and you as an audience with the great questions you contributed. So thanks a lot to all of you. And with that, I think we start the next session, which is panel 1, Contexts and Diversity in Models.
So breaks are overestimated in this conference in total, I think. So we will directly dive into the next session. And the next session is a so-called panel. That means that there is one introductory keynote lecture, which I will introduce in a second. Then there will be 4 short 7-minute presentations, and then there will be a discussion round. Therefore, you're seeing the chairs there, where you can also actively participate and ask questions to the panelists. This panel is about contact behavior and heterogeneity and diversity. And we are very, very happy and lucky that Luca Ferretti from the Big Data Institute and the Pandemic Sciences Institute at the University of Oxford is with us today. He will present work from one of the, I think, very successful modeling works during the pandemic, which is the work on the contact tracing app in the UK, which Luca mostly led. And we're very grateful that you're here today and present this exciting work. Thank you.
Thanks a lot, Ander, for the nice introduction. So, jumping to what I will discuss today, I think you all know what digital contact tracing is. It is essentially an approach to do standard contact tracing, but measuring interactions through Bluetooth exchanges, so short distance measures of distance and duration of contact. It was widely deployed during this pandemic, with most implementation being based on the Google and Apple exposure notification, and therefore very privacy preserving and enabling very little data to be collected from an epidemiological perspective. The reasons were the usual one. These approaches, being digital, are scalable, they are fast, and they can also notify contacts that are unknown to the index case. But it is not the main focus of what I want to discuss today. So most of my work has been on the NHS contact tracing app that has been developed for England and Wales with a series of functions, but the main one was always contact tracing. In terms of effectiveness, we have estimates that the app averted at least 1 million cases in its first year, which is probably a conservative estimate since we know that it averted between 300,000 and 600,000 cases, so between 15% and 30% of all cases just during the first 3 months of operativity in autumn 2020. So we had lots of analytics that we used in order to assess how well the app worked. But there is something else that you can do with the app analytics that we have. It is trying to do some precision epidemiology through this data. So the first topic that I would like to show you is about transmission risk versus proximity and duration. First, the first question that we have to ask is, are these apps actually fulfilling the major role of measuring accurately the risks of transmission? So the mental model that we all have, and this is the same that is implemented in the app, is essentially that the risk is the product of some proximity factor times the duration of contact times some infectiousness that for this app was actually negligible, unfortunately. So this app essentially uses proximity and duration for technical reasons. And we had a quite good anonymous data analytics environment, and we were able to obtain high-quality data from about 7 million contacts that were monitored for about 23 million hours of exposure, just to give you an idea of the kind of data. Now, first, just to check that the app was working. If the app would be working, you would expect that the risk measured by the app for at least the closest window, that is the one on the x-axis, would some way lead to a monotonic relation with the probability of reporting a positive test. That is what you get. So the higher the risk measured by the app, and the higher the probability that the contact actually tested positive. You can do a statistical analysis and try to estimate the actual probability of transmission per 30-minute window, followed by reporting a positive test, as a function of what the app measured to be the risk, as a product of proximity and duration. And if the app would measure things properly, you would expect a straight line between these two quantities. And this is quite close to what we get. At least for low risks, you see a clearly linear relation between risk as measured by the app and the actual probability of transmission from the case to the contact. So now that we know that the app works well in estimating transmission risk, we can start asking epidemiological questions. And there are many questions that for which answers would be quite important. The first one is, what are the determinants of transmission? And we get an unsurprising answer, but it's an answer that has been too often forgotten. It is duration of exposure matters, and it's actually the main determinant of transmission. So the probability of transmission followed by a positive test. I'm always saying that it should be followed by a positive test because not everybody in the UK was getting tested. So this is not the actual probability of transmission. There is some ascertainment factor between, let's say, between 1.5 to 3. So, for example, when you look at the probability of transmission in these log-log plots, you see that this orange line for low durations, well, this line in log-log scale has a coefficient of 1. So essentially, probability of transmission increases linearly with duration for short durations. And the rate is about 1.1% per hour, the observed one, which means that probably the probability of COVID transmission per hour is about 2%, give or take. And you see that after 3 hours of exposure, it starts increasing sublinearly. There is some saturation. But the interesting thing is that it keeps increasing after even 50 hours of the continuous exposure. So we're talking probably about several days of exposure. So even in households, some transmissions occur after, just after very, very long exposures. Now, if you want to assess what is the actual risk of transmission in the population, you need to know how proximity and duration of contacts and transmission are distributed in the population. So if you look at the blue part of these plots, they illustrate the closest proximity, basically, on the left in the population, and the duration of exposure on the right. And you see that, of course, we have lots of contacts that tend to be far away from us, and we meet just a few people very closely during each day. And the same for the duration of exposure. Most of the contacts are half an hour to 1 hour. We don't see shorter contacts, essentially. And then there is a tail of people that we meet for 10 to 50 hours in workplaces and households. If you look at transmissions are instead wide, so the red part of these plots. Transmissions come from a wide range of proximities and a very wide range of durations. So if you would ask for COVID-19, what is the typical duration associated with transmission? Well, in the population, we have uniformly every duration from half an hour to 50 hours. And more or less each scale of duration has more or less the same weight in terms of population-level transmissions, which is maybe expected to some extent, but unfortunate because it means that to stop effectively transmission, you also have to take into account quite short-term exposures. This gives you a picture depending on that essentially separates contacts, transmission, and so on, depending on what are some features that we are able to extract from the data. So putative households are essentially contacts that last for more than 8 hours each day. In England and Wales, the typical working day is 7.5 hours. So if we see that people are together for 8 hours, that is most likely household exposures. And then there are some exposures in green that are the ones that occur for multiple days. Could be workplaces or similar environments. And the other are single-day exposures or short single-day exposures. And you see that if you look at contacts, of course, households account for like 6% of all contacts, and maybe 20%, something like that, is recurring exposures. And the others are overwhelmingly single-day exposures, typically short ones. If you look at the cumulative duration or the cumulative risk of transmission, they are more or less the same. You see that households account for more than 50% of the duration of the contacts, and the recurring contacts account for another 20-25%. And this, of course, is what influences transmission, because duration is an important factor. So if you look at transmissions, households are responsible for about 42%, let's say 40-something% of transmissions in the UK. Recurring interactions, workplaces, and so on are responsible for 25%, and there is very little left. So actually, the epidemic in the UK is likely to be quite generalized and driven by households and workplaces to a large extent, or other contacts that are regular contacts occurring over multiple days. The second thing that we wanted to do, rather than investigating just the aspect of transmission epidemiology, we want to investigate if we can use the app for epidemiological monitoring. This is actually something that we did during the pandemic. So the question is, can we use the data of the app to reconstruct the dynamic of the epidemic? So the advantage of the app is that the app measures exposures and transmissions retrospectively the day they occur rather than the day they get reported. So for example, if you look at the orange line would be essentially measuring the number of contacts that infected individuals have by the day the contact gets notified. And so you see the smoothing, of course, and the delay that is inherent in this. If you look at the rest of the distribution, that is the kind of resolution that we get through the app, which is literally the daily resolution. So we see contacts the day they occur. And so this is the kind of picture. You see the weekly periodicity, and you see the weekly distribution of risk by color. And you can do the same with infections. So these are essentially infections by the day we believe the individual has been infected. And you see that essentially there is a very fine-grained structure with specific events triggering a wave of infections. You can decompose these, of course, by type, households, and so on. Here you see the very clear Christmas peak, for example, in the upper plot with the peak of contacts during Christmas. And of course, this leads to day of the week effects. This is, for example, distribution of infections across day of the week for the different categories that I was showing. Of course, you expect households have a quite wide distribution, peaked on Sundays, while for example, single-day contacts tend to have a quite peak distribution on Saturdays. And this is the kind of monitoring that one would like to see, possibly at even fine-grained level. If we look again at the number of infections per day, per type of contact, you see some interesting dynamic there. For example, you see the big peak in households. That is Christmas. That of course corresponds to a big peak in people coming together and getting infected. If you look at single-day exposures or short of single-day exposures at the bottom, you see two periods. One is the period in December that corresponded to in this case, to the early Omicron wave, together with Christmas shopping. Christmas shopping, you see the peaks during the weekends, is a big driver of epidemic spread in December. The other interesting peak that is around there, Viola knows it very well. I can see she's saying, yeah, I know. That's the Euro 2020. That she nicely published already about this, showing that England was an outlier, and England is actually, so this is the most impressive event of the pandemic in England. And so to show you a zoom around this period and showing you why this data is cool. This data is cool because you can separate the role of contacts and the probability of transmission in causing infections. And of course, contacts and probability of transmission come from very different behavioral, social, and biological components. And you can look at both of them together. So this is the period of the Euro 2020, and the three lines are all infections, all contacts, and also the probability of infection per contact. I put them in log scale so that the curve of the infection is the sum of the other two curves, so you can see what contributes. And of course, this is only for England, and I'm showing you the football matches. You can see the peaks. This is the first one against Croatia, second one against Scotland, third one against Czech Republic, and you can see the contribution of both contacts, so high number of contacts, and large infectiousness. This is not surprise. You can guess that. Sorry, this is against Germany. Apologies. And you can go on with against Ukraine, against Denmark, and finally the final against Italy. Well, unfortunately for them, I usually present this in England, and people are not happy, but okay. And you can see how things were driven by a combination of increased number of contacts, people going together in pubs, groups of friends, and increased infectiousness, people drinking together, shouting, possibly, and congregating in small environments. You can see another peak, curiously enough, in the middle. It is not a match, you see. That peak has a peak in contacts, but not in infections. That is the last game of Wales. So English people were that day were looking forward to see how Wales was performing, but they were not, of course, shouting or drinking because they didn't care that much if Wales was winning or losing. And you can see the mismatch between the number of contacts and the infections. Sorry, and the probability of transmission. So what we did during the pandemic was essentially doing this a little bit less resolution for technical reasons, but to measure RT in real time. So essentially you can measure the rate of contacts, you can measure the probability of transmission, and you can multiply them and get an estimate of RT. We don't know the exact contact rates and the exact probability of transmission because there are certain factors, but we can get them up to a constant, basically, and that is good enough to get the trend of the pandemic. So basically, here you see on the top, the reported number of contacts per case throughout a couple of years of the pandemic. The second line is the reported second attack rate during the pandemic. These were literally the plots that we were giving to the British government. And the last one is the indicator, is a microscopic indicator in this case of the app-based RT. We usually think of RT as something that we measure from case data and trends, but this is the literally microscopic one, looking at how many infections are caused by a single case on average. So this is, for example, what contacts look like in the Christmas season, just zooming for 2 years over the Christmas season. And you can see a bit of peak during the Christmas shopping in December, and then the lull, the dry January, as they call it in England, during the Christmas holidays and a bit later, which is basically a self-imposed lockdown for the country. You can see the lockdown level. But I think the nicer plot, from my perspective, is this one. So on the top, I'm showing you RT, and on the bottom one, RT in, on the bottom one, so the blue line is relative RT, relative to some median level. And the two color blocks are the contribution of essentially transmissibility in red, so second attack rate if you want, and in green you see the contribution of contact rates. So you can literally read if for any given point in time it was the number of contacts that was driving the epidemic, or it was the transmissibility. And you can see that for the first year before Omicron, basically, a lot of the epidemic was driven by contacts, unsurprisingly, because there were restrictions, there were a series of behaviors, and here there are only two variants. There is alpha at the beginning and then delta. So you see a big wave around June, driven entirely by contacts. This was the reopening after the restrictions of the lockdown, essentially, in England. And you see that delta had a very little impact. It was all impact of contacts. You can see in midway through the plot, there is a big wave of transmissions in December, January 2020. And you can see that it's a combination of the Christmas shopping that starts it, and then the effect of the second attack rate that is increased due to Omicron in the same period. And then after Omicron, essentially contact rates become irrelevant. The rest of the dynamic is basically driven by second attack rate, which is not surprising because we know that essentially the dynamic has been driven by successive waves and immune escape. And of course, the immunological landscape is almost only captured by second attack rates. And of course, in principle, you can even get a little bit more fine-grained pictures, but I didn't bother for now because of technical reasons, but you could get this resolution at the daily level. So the interesting thing of this data, and similar data that is becoming available, is the possibility to move towards precision epidemiology. digital contact tracing is one of the tools that enables us not only to work towards epidemic control, but also to have effective epidemic monitoring and precision epidemiology, measuring transmission risks and factors influencing them. And you can measure these things at the individual population level. So this opens quite some new opportunities for epidemic management and control that I think we should try to capture as much as possible. And many of the lessons learned, for example, the importance of duration, those are likely to apply to any respiratory pathogen. So duration was something that, as modelers, I mean, most of you were well aware of. If you model transmission, you model it proportional to duration. But in public health, that was not, in the absence of hard data, that wasn't widely appreciated, and many of the guidelines were more worried about proximity and duration. And that is something that probably we should rethink. And then the last thing is that, unfortunately, setting up this infrastructure takes time. It took us a lot of time to learn how to use this data. And of course, it's the kind of thing that you have to prepare in peacetime, and you have to start thinking about how to set up both the infrastructure and the analysis in normal times. And this is something that we are still not doing that much, but there's always time, I hope. Thanks.
Thank you, Luca, for this fantastic presentation on the groundbreaking work. Can you stay for a second? Because I would like to allow a few questions, because I think this was such a groundbreaking presentation. Martin.
Yeah, thank you very much again. I had a question on the definition of the proximity of contacts. So how did you come up with 10 hours or 50 hours of contacts? Because you would change the room, or so what's the definition of proximity that allows a contact for 8, 10 or 50 hours?
Is that the audio here is awful, so I cannot hear the questions if I stay here. I got it. So basically, the app measures proximity with some caveats and the duration, and there is a sort of minimum proximity well, actually, minimum combination of proximity and duration for a certain time is the equivalent of the 2 meter 15 minutes rule that was widely used in many countries. So you can think of it as a risk level, and the app measures all combination of proximity and duration that is able to capture that have at least the same risk as 2 meters 15 minutes for each half an hour. So that is essentially what the app is capturing. So broadly speaking, it doesn't consider proximity if the proximity is too far away. The theory is that you should, I mean, maybe you can reach a few meters. So it's hard to say because the Bluetooth is actually a rough measure, but it probably captures interactions up to several meters away, but they have to last long enough. If they are several meters away, they have to last long enough in a single half an hour. So that is the way. And then you accumulate that duration across all the interactions that you are able to get.
So my question is probably related to what was asked before, but it's about exposure. So how do you actually define this exposure? So the people kind of reported their actual infections to the app, and that was like how exposure defined, or maybe can you comment on this?
So here an exposure is defined as essentially an exposure to a confirmed COVID-19 case. So basically, for the app to work, individuals had to essentially get a positive test and insert a code from this test into the app. So we know that when it was an exposure to a known confirmed COVID-19 case. So an important difference in these contact rates compared to the contact rates from, for example, from mobile data, is that these contact rates are restricted to the component of the population that is currently infected. So it's literally the contact rate that you would use for RT. which of course may be different to the one that you have in the general population.
Yeah, thank you very much for this very nice presentation. I have a very different question. Can you comment briefly on the sustainability of the infrastructure, the data collection basically? Is this still running? How is this going to proceed? And maybe also on the topic of funding, if it's still running basically.
Big and painful question, mostly because essentially the apps have been shut down because of the infrastructure. Sustainability, the truth is that compared to any other cost, the cost of the system was significant in terms of just the infrastructure would cost order of a few millions per year on the low side. I mean, the cost of the whole UK app, including a lot of development, was around, I think, 50 million, give or take. But usually these costs are negligible. What is expensive is testing, as you know. I mean, if you have a testing infrastructure, the app costs nothing, because essentially the app is a way to decentralize essentially public health. So using the support of the public support and using all the funds. The cost itself is not a problem. The issue is more in peacetime, there is no pressure to build this kind of approaches, no pressure to keep them running. So, I mean, the issue is not even a matter of cost, because keeping it in standby wouldn't cost much. It's just a matter that the Google Apple protocol for now is dead, and other protocols are there, but if you don't prepare them in advance, I mean, just making sense of the data, building the analytics has taken quite some time, and if you don't prepare it when you get the outbreak, that delay, I mean, I believe that these approaches would be really useful to have early in an outbreak to measure, I mean, forgetting about epidemic control, to measure epidemiological parameters accurately at the beginning of the epidemic, possibly asking for data donation and getting data on context. So essentially, doing manual tracing the digital way as much as possible in order to speed up just to speed up the process of learning epidemiological parameters for new pathogens. I think this would be key, but this is something that we would need to prepare, and I cannot see the political will for now in most countries.
Okay, thanks again, Luca, for answering the questions, and thanks for the questions. I always think back at the first months of the pandemic when we were discussing also in Germany potential use of infrastructure, just as Luca just presented. Luca was involved in that, and unfortunately that didn't materialize. So this is one of the very few situations in past and present where both contact behavior and infection dynamics are measured in the same data set. Yeah, that's very, very rare. So this is unbelievably important data. And it also shows us that with more complex research questions, more heterogeneous models which we use, parameterizing contact behavior becomes more and more difficult. And that is what the next 4 talks try to introduce to the discussion somehow. And the first presentation is from Veronika Jäger, who's the head of infectious disease epidemiology at the University of Münster, and she will introduce different ways to collect contact data and set the ground for the following presentations. Thanks.
Thank you very much. And I've just seen that I have the same problem as some before, so my slides are a bit, we'll see how it goes, but they shouldn't look like that. Let's see if the animations come here. So I have 7 minutes time to set the scene a bit for you. We'll see how that goes. We are at a modeling conference, so I guess you all know a bit about that. What do we need to build a model? You want a model structure. Okay, that doesn't work. And you need something to parameterize, but of course we also need to know about the population and the contact patterns. And Jan Pablo will talk about Gesiland right after me, and I'll introduce you a bit to contacts. Next 7 minutes, or 6.5 now, I'll quickly introduce you to contact surveys, a bit of mobility, and mobile phone data, and a bit of sensors as well, just because these are currently used in various of the consortia of MONID and have been used in the pandemic throughout. To start with are contact surveys, and I will spend most of my time talking about them just because they are great and very dear to my heart. And many people still regard them as the gold standard of collecting data on contact information. So how do they work? It's pretty much you ask people. You ask people on paper or you ask people online, different groups of people, and you ask them, whom did you have contact with? What age was the person you had contact with? Where did the contact happen? And you usually, traditionally ask them for a time period of 24 hours or maybe a bit longer, and you can do that in as much detail as you want. A couple of examples to get you set for the next talks. Well, the greatest example, and I'm pretty sure many of you will know it, if not, that's the time for it now, is PolyMod. PolyMod was a study run almost 20 years ago in 8 European countries. And I've just brought you 1 or 2 slides from that. And you can see that Germany is in the light blue, so the first ones, and on the y-axis you have the mean number of contacts, and on the x-axis the age of the participants. And the one thing you can see from that Germans are not very social people, because we don't have a lot of contacts, at least 20 years ago. It might have changed now. Another classic way of looking at contacts, and again, this is from PolyMod, are contact matrices. So you have on the x-axis the age of the participant, and on the y-axis the age of the contacts. In this case, as lighter the color, as more contacts participants had with contacts of that age group, and as darker the color, as less participants they had. And you see a very classic pattern, this diagonal here, just the assortative mixing. So usually people mix with people in their bubble, quite often also age-wise within their bubble. That was 20 years ago. Then the pandemic came up, and contacts were suddenly very important. There were very many studies set up, very many contact surveys set up throughout Europe as well. In many European countries, the COMIX survey did run. We in Germany are also sort of associated with COMIX. We did set up the COVIMOD study, which was running from 2020, so this is April 2020, up to the end of 2021, and we do have a couple of surveys later on. And again, on the y-axis, this is just the mean number of contacts. And you can see that in the beginning, the number of contacts did go up. They were really low in the beginning because we were still in the lockdown. And then later on, as time went on, we had a bit of up and down. And this brings us to some pros and cons of contact surveys. Pros are definitely, of course, that we have individual data on individual participants, and we do know a lot about the contacts as well. That's a bit up to us, what we ask of participants. We have demographics of the participants and so on. So that's great, and we need that for a lot of information, but there are, of course, also cons to that. It's quite time-consuming to get that. It's quite expensive. If you do it longitudinally, as we did, we ran into a lot of problems that people got really fatigued of filling in the questionnaire. So we did see that participants who kept on taking part in the studies actually recorded less and less contacts. And of course, in this case, we need to define what a contact is for us so that the participants know what a contact is. Traditionally, it is that you talk to people, or you're close, or you touch them. That won't help too much. You all remember SARS-CoV-2, aerosol transmission. That might not be enough to define all those as contacts, because their contact could also be somebody sitting in the restaurant right behind you. But we are still using a lot of COVIMOD data throughout the MONID consortium. Another one, which I'm also going to spend a bit less time on, is mobile phone data. And we are in optimization, for example, using NetCheck data. So how is that working? So they are saying, okay, if we have mobile phones with a specific app, so the Clever Tanken app in this case, for example, installed, if they meet anywhere in a square of 8 to 8 meters for a period of time, then they are regarded a contact. And this is, of course, much easier and much faster to get all that data, but of course you don't have the entire population covering that. But examples are, for example, the net check data, and then you also have mean number of contacts over a time frame, and these are used throughout the consortium. Pros and cons again. Pros are pretty clear. You have a large data set, you're rather quick, but we only have aggregated information in this case. We don't have information on individual participants or individual contacts. What was also used quite a lot in Germany throughout the pandemic is mobility data, for example, Google Mobility or Apple Mobility. That was started in 2020 up to 2022, Google Mobility, for example. They were just having, if you had your location setting on your phone, Google tracked that. The same way as Google does, if you go to a restaurant and you search for it in Google Maps, it's the same way that it says if it's busy or not. They use the same way here. Example-wise again, they do this for different settings, for example, residential or transition or workplaces, and that was used a lot in Germany as a part of contacts. Pros and cons similar to the mobile phone data, that the definition of a contact is a very different one. But of course, it's easy to get lots of data really quickly. Sensors are only going very, very quickly because I think we have a restart session afterwards, which will include sensors, but sensors is pretty much that two people wear a sensor, and then if you meet somebody, the sensors actually get in contact and send a note out that you had contact. But restart, we'll talk about that. And just to finish off, saying we are working on OptimAgent in the sub-project 1. We are working quite a bit on that, heterogeneity in contacts and contact behavior, and there are loads of posters out. I think many of you have seen loads of contact posters during the poster talk already, but if you haven't, have a look at them. And thank you for that, and now I think we have the next setting the scene talk.
Yeah, thanks a lot, Veronica, for the nice presentation. This part of the session works without questions, so we will directly switch to Pablo Bogart's presentation, who unfortunately has not been able to come due to strike reasons. He's from the University of Trier, social statistics, and I hope very much that we see him and his presentation in a second. And yes, we do, both of that. So great to see you, Pablo. And he will introduce Gesiland, which is the population for the agent-based whole population model in OptimAgent, and will give another perspective on how contacts work, because that is more or less the automatic way in agent-based models how contacts can be implemented by just defining the population.
Okay. Hello, everybody. Can you hear me?
Yes, very well.
Perfect. So thank you. Yeah, I would have loved to be there with you and chat and have a nice time, but well, next year. I will present my part of the OptimAgent project, and this is about a synthetic population of Germany. And this population will be open access, so everybody of you can use it in future for teaching and research. And the key features of this data set will be that you will have a georeference data set linked to OpenStreetMap. Additionally, you will have in this data set quite a lot of heterogeneities. So the households compositions will be as heterogeneous as possible, according to the real population, of course. We will have prevalences for relevant diseases, and also we will have commuting structures for workers and others. And the main focus of this data set is, of course, for epidemiological modeling, but it will be also applicable to other areas or areas in between. and it will cover only residents in Germany, so no cross borders will be taken into account. Of course, this will be not a real population, a synthetic one, and so we cannot take the real households from a survey and just replicate them into the population, because then we could not make them open access. Today I would like to show you some points where we have heterogeneities inside. And so first, our building structure. So every person will be living in an apartment, and this apartment will be in a building. And these buildings, they are deduced from the German Census 2011 dataset, where we have the number of buildings in a 100 times 100 square meters grid cell. And I think by seeing this size of the, or this granularity of the information, we see that we will have the heterogeneity of buildings in Germany quite well covered. The information on these buildings will be, for example, the number of apartments, but also whether it has a main heating system, which is the main heating system, or other information like whether it's from a landlord or not. What we do with these buildings that we generate out of these tables within the grid cells is that we link them to buildings that are available in OpenStreetMap's data. So this link will be not perfect, but we will have the building sizes in the 100-meter cells.
Pablo, we don't see your entire screen, unfortunately. Can you try to
reshare? Yeah, I share in a different way. Let me see. Is this better?
Yes, thanks a lot.
Okay, perfect. All right. So then the apartments, these are apartments that reside in the buildings. Again, we take here the census information, so we will have very fine-grained information on the apartment sizes. We have the apartment size, number of rooms, the number of persons living in this apartment. Again, this table is on a 100-meter cell grid, so we have very, very high resolution of the sizes of the apartments. And here in this point, we will have to make a little simplification. So for us, every apartment forms a household. So all people in a household live in the same apartment, and all people in an apartment are in the same household. I think for our purposes in epidemiological modeling, this is okay. Economists will not be very happy about it, but I think for epidemiological modeling, this is an acceptable simplification. So the next thing is that we will have family structures within these households. These family structures, they are derived from the microcensus 2019, because the 2020 microcensus is of a new kind. It's a redesign, and there's still some issues with the data set, so we stayed with 2019, but this can be updated in future. So what we do is basically we have from the 100-meter cell grid the size of the households, and then we look in our microcensus and make probability tables for the household sizes. Within the household sizes, we make probability table for the family types. Yeah, so single living person or married couple with children. So they have all different family types. And within these family types, we make a probability distribution based on the oldest person. And for each oldest person in a family type, in a household size, we will have an age-gender distribution of all units or all persons living in that household. So we will have a very, very fine-grained probability distribution here at the end for all the different types of households, and everything will be covered quite nicely. And as soon as we build up this probability distribution, afterwards we just draw from this probability distribution. And this probability distribution will also be generated by the Länder separately. So in each land, you will have the correct distribution for that land. So for Palatinate, Sachsen or Berlin. Then a next problem was the educational variables, because the educational variables always depend on the persons within the household. So if the oldest person in the household has a high education level, then the second oldest most probably will be also of a high education level. Yeah. So for example, a married couple. Hence, we will have to somehow base the information or the generation process on the older persons in the household. And this is what we are basically doing. So the first person in the household will be generated education information based on age, gender, and nationality. And for the second person in the household, also the age, gender, nationality, and the predicted education for the first person in the household will be used as an additional information. For all other, so third till eighth person or something like this, these two first persons will be as an auxiliary information, and then the prediction will be done according to this auxiliary information. Next, we have we impose a structure on this population in terms of where do you work and where you go to school, and this is the occupation variable. So the occupation basically stores what the main occupation of the person is. So it's going to school, for example, for pupils, or you go to workplace. And basically, what happens is that you will have then in this occupation variable a vector, with the first entry being the building ID, so you know in which building this occupation will be, and then the setting variables. So this could be, for example, that you have a building which has a school, and at the same time has, for example, a cafeteria. So the students, the pupils, go to the school, and maybe they go to the first grade and the second class in the first grade. So you will have the information in the settings variable in which class this pupil is. And of course, in the same building, there could be also a cafeteria where the people preparing the meals will be working. So they will have a different setting variable there, but the same building ID. This way you can get all the units that work in a building and also within different levels of setting. So within the school, within this class year, or the school class itself. And this will be then in the location. So the buildings will have locations, and for example, school class is a location setting. And also here the information is included where all the PIDs, so the person information IDs, will be stored. So it is very simple access to get all the persons that are in one class. Yeah, so this is designed such that you can get very, very fast the link from a person to the place where it works, and from the place where the work is to get all the persons that are in that setting. So the workplaces, we are not absolutely ready yet. There's one last step missing. So we produced a workplace population, and which comes from official statistics tables, and we updated it with the Handelsregister. So this is available, and now we have to somehow match the workplaces to the persons based on their educational level, and of course also their profession. And the next step will be to include health variables based on the GIDA data set. And here my question is to you, all of you who are going to take this data set and work with it, which are the most relevant health variables that you would like to have included here, and which heterogeneities are important to you in this data set. So if you have ideas what you think it's important from this GADA data set, or you have other data sets where you have information variables that you would like to have included in this GESILAND data set, you can send me the surveys that you have, and I will try to implement these variables. Here's my email address, and I will be happy to help you if it's possible. Thank you.
So thanks a lot, Pablo, for this nice presentation. It shows the other end, contact behavior, because by a very detailed population structure, possibilities to implement actively contact behavior are very limited, and David Kerkman in his next presentation will show how that could work, or a bit of theory on how it maybe should work.
structure of the agent-based model briefly and then bring everything together. So I will make a short summary here what I will be presenting. So the first part will just be an overview of the agent-based model. Then I'll show you how the contact model is implemented and then how to use actual contact functions that we might derive to have a better estimate on how people actually meet in the locations. So this is a brief overview of our agent-based model. So we have the agents that can move between the locations. So these locations are actually in place. So this is very similar to the setup that Pablo just described. We have actual locations where people can go to and people can move through during the simulation. And this obviously is connected via some policies and interventions that prohibit people from going there or have some restrictions, and also the infections, but this is not part of the talk today. Okay, so when people move between these locations, one would have to know, okay, who do they actually make contact with? So as we do not have an explicit contact network per se, we need to know, okay, there are like a couple of people now at this location, and who do you actually make contact with, and how much, and so on, and how do you derive your infectivity from that? Okay. Apparently the formulas did not get copied correctly here. But luckily we had the talk from Luca before, who showed that basically we have the product of exposure time or exposure as some value, which I will not go into detail here, times the contacts that you have, right? So we basically sum up here over all the age groups that you can have contact with and multiply the exposure by the contacts. And if you're interested in how we compute the exposure and more details about the agent-based model, I will again advertise for my talk tomorrow morning about the agent-based model. But here it's about the contacts. So these are some of the daily contact patterns that were used in a previous publication, where we have used different ways to get mean average contacts for the individual location types. So, for example, you could see home, school, work, or other places here. And for school, obviously, the younger population would have more contacts, and then work more the middle-aged population, and then it's a bit stretched out for home and other locations. And this reflects a local constant contact rate. I call it CL here, depends on the location, but this is constant through the day. And this is a bit of a problem for agent-based models, because this is not entirely true, right? So this is a good estimate for ODE-based models, where you have an average amount of contacts that you have, and you just plug that in as a parameter. But for agent-based models, it would be nice to know, how does your contact behavior actually depend on what people are in your location, and how many of which age group, and so on. So it's not quite as trivial as having a constant contact rate. So this is, I mean, you can use that. It's the first order approximation, okay? But, wow, okay. So what would be nice to have is some contact functions called CF here that not only depend on the location, but also on the amount of people that are in the location, right? And the idea then is to have some kind of fitting, so that we have here on the left side these average contacts that you have per day multiplied by the total number of people in the age group, and you want to set that equal to the right-hand side, which is this here, where you just sum up over all the locations and over the entire day the amount of contacts that you have. And you try to fit the parameters of your contact functions through this equation. Now you need two things for this. The first thing is the knowledge about individual movement behavior. So you need to know where the people actually are to be able to fill in those xi. And the second thing is to have a sensible contact function. So you just want to have a general idea on how to set these functions. So for the first point, things that we plan to use is some kind of result that we have for trips that are in a city-based scale. So we have a data set that tells us, okay, this is a synthetic population, and people move from one location to another, and we have the fixed times when they do that, and the location IDs. So here the locations are actually mapped into the people, so -1 is a home and -2 is a work, and so on. And we have we exactly know where everybody is at which time point. So this is very nice, because then we already know the XIs, right? So how many people of which age group are at each location, so we can evaluate these contact functions. What's maybe a bit more tricky is the question about which contact functions to use. And I would like to go through a couple of sensible contact functions that you can assume here. So the first one would be just constant contacts. So this is the same that we had before, where we said the contacts are only dependent on the location. So here it's called C0, but it's basically dependent on L. And these are very useful for purpose-oriented contacts, meaning that if you have an intention to meet somebody, then you will make a certain amount of contacts, right, independent of how many other people are in the room. So if I work with somebody at work, one person, I'll meet this person, and I'll have contact, and if there are 15 more people, I don't really care. This is constant. But then there's also other ways of contact. So this one would be, for example, that as constant C1 multiplied by the actual number x1 in age group 1 divided by the whole number of people in the location. So this is then a distribution over how many people of each age group are there, and then the contacts are linear to this factor of the distribution of people in the age groups. And this is good for non-purpose-oriented contacts or unintentional contacts, because you will just meet people at random. One more, well, these are overlapping a bit here. But one more similar thing is that you have some constant C2 times the number of people in the location in age group 1 divided by the location size. So this is also very important for non-purpose-oriented contacts. If you imagine you're in a football stadium and there are 2 people in there, the likelihood of meeting that other people in a non-intentional contact is very low. But if you have a room that's just 2 square meters, the contact chance is very high, right? So these are very sensible functions to use. And a good idea might be to use a combination of all of these contact functions as a setup to compute your parameters, and therefore a better approximation of how your contact level actually looks like. So yeah, this is the proposition that we have, and we are in development of computing this, and I'm very open also to discussion and other ideas of sensible contact functions that you might propose as being very sensible to use. And with that, that's the end of my presentation, and I'm very open to questions.
Thanks a lot, David. And now we hand over to the final presentation of the session before we go into the discussion, which is given by Beate Jahn from UMIT in Tirol. And she will show us the other end of the infection dynamics, the consequences and heterogeneity in consequences in health inequalities. So if we have the question why we should take into account heterogeneity in contact behavior, of course, it's important to get the overall dynamics right, but often we are also interested in specific subpopulations in a population, and Beate will show us why this might be very important.
Yeah, thank you, and I'm very happy now to finally bring things together when we look at the data, at our results, and when we are concerned about measuring health inequalities. So, first of all, what are health inequalities? These are systematic differences in the health status of different population groups. And these inequalities have significant social and economic costs to both individuals and us as a society. And of course, we do care about this. What you can see here, a lot of publications coming out, and also people thinking about and talking about mitigation on inequalities, and also there is methodological research on how to evaluate the impact of interventions and how to best capture inequalities. But here within this group, I would like to maybe first start a little simple. Health inequalities, what are the drivers that we need to consider? First of all, it is health behavior or risk factors that we can incorporate into our models and then also evaluate. It is also psychological factors. It is unequal access to or experience of health service. And it is also wider health determinants, such as environment, income, or housing. Measuring health inequalities, well, it is important in order to inform equity-oriented policies and programs, measures that we implement. Before we can do this, we need to think deeply about the outcomes, about the health indicators that are relevant, death, hospitalization rates, or case fatality rates, or looking at quality-adjusted life years. Finally, then looking at the inequality dimensions. So where do we expect these inequalities, or where do we know about it? Thinking of sex, age, vulnerable groups, socioeconomic groups. And then there is the question about our outcomes. So do we look at the results, at the outcome, in a disaggregated or in an aggregated way? Having the opportunity to look at it in an aggregated summary and using aggregated summary measures, here inequality in population are quantified in a single number. And so we can compare health inequalities over time and also across different regions, etc. We know from economics where inequalities in incomes, they are looked at using kind of the Gini index or Atkinson scores and so on. And the application of measures in healthcare, here there is a nice overview presented in a most recent systematic review, looking at summary measures in a simple or in a complex way, where we either can have absolute measures or relative measures. And you see quite a lot, and I don't have time to go into all of these potential measures to be applied, but just as a quick summary, for the simple measures where, for example, we use differences, ratios, weighting, here we weight all population subgroups equally. These measures are easy to interpret. We can use them and calculate them for any types of inequality dimensions. However, they ignore the situation in other subgroups, and they don't account for population size of each subgroup. This is done using complex measures, however, such as concentration index or mean difference from best groups. So here, within these complex measures, we consider all population subgroups. And it helps us to understand better the concentration among the different subgroups in our population, such as socioeconomic groups and so on. However, it is much harder to, or even more challenging to calculate and to interpret. And for some of these measures, when we need reference points, such as the most advantaged or best performing subgroup, there we also include normative assumptions within our decision making. These health equity measures are already applied. They are already applied also in the context of COVID, for example, using a tool at the WHO, Heat and Heat Plus, where you can already use your own data set and evaluate health inequalities in a disaggregated and in an aggregated way. However, what is missing here is the comparison of effects of different interventions. And this is coming from a decision analytic modeling, decision analysis background, extremely important. When we look at what has been done in the evaluation of interventions, systematic reviews show that for the evaluation of several interventions, the most often age-specific estimates were used, and only rarely non-age-specific subgroups. So also for the vaccination evaluations, here we see that, of course, results are presented within age groups. However, none of the studies conducted, for example, distributional equity impact analysis. Distributional equity impact analysis meaning that we look at the effect of the intervention and also, as you can see it here on the graph, the efficiency impact and the equity impact. And with the equity impact, if we want to have a look at a comparison such as this, we would need these summary measures. Going a little bit beyond these, we also have the methodological development in the field of GRACE, so generalized risk-adjusted cost effectiveness. I don't think that we will go that far within our project in OptimAgent sub-project 6. However, what we do is, in our evaluation, we would like to inform decision makers and incorporate these aspects and to show the trade-off between our choices of intervention in terms of efficiency and equity, benefit, harm, and cost effectiveness, equity considerations. To do so, it is important, and this is where we are now working on, to set up a framework up front together with the decision makers. And here we had our first interviews in order to find out what is the most relevant intervention or bundle of interventions we look at, what are the outcomes, inequality dimensions that matter, and also to discuss disaggregated and aggregated measures that are acceptable. And of course, and this now links to the other talks, we need to not only look at these equity, but also we need to incorporate these information finally in the model. So the impact of the disease and the intervention specific for our subgroups that we focus on, they need to be incorporated in the model, and therefore we need further model input. With this, I'm at the end of my presentation, looking forward to the discussion. I would like to thank the modeling team at UMIT. Thank you.
Thanks, Beate, for this very nice presentation. I would like to ask all presenters to come on stage, please, of this final session, as well as Miriam Kretschmer, who, because Pablo cannot be here, will also take part in the discussion, and I'm very grateful for that. Raphael will take care of getting your questions to the panel, but while all of you are joining there, I would like to start with a little bit maybe populistic question. Now we have seen Luca's data, we have seen a very complex agent-based population brought in by Pablo, which defines the duration of people in different settings quite a lot. We have seen from Luca that, of course, duration somehow matters, and maybe contact information derived from this population might be good enough for agent-based modeling. So is there any need for collecting contact data outside of population structures which are already given in agent-based models? So in front of you are mics, so please comment if you want. Okay. Okay, so
Yes.
Unfortunately, it's impossible to hear here what's being said down there. So what I ask the probabilistic question if there's any need of collecting contact data anymore, if we have models so complex as Pablo's population, which is there, which more or less defines where everybody is at every point in time. And Luca's study, to some extent, showed that this might be the central information unit we might be interested in. So is there any additional value in collecting contact information outside of knowing where everybody in a population is at any given time point?
Yeah, so does this microphone also work? Yes, perfect. Okay, so yeah, this is, I think, quite well connected to the presentation that I gave, where I tried to not only have the average contact, but rather the more specific contact behavior of people in the different locations. So I think one could, if there was more of a tracking of how exactly people behave inside the location, which partly there is, but there could be more, then we could just use that and not have to do all this fitting that I presented, but already have quite a detailed knowledge about how exactly the people meet and use that immediately in the models.
Well, I would say we still need to collect contact data, because I think that even in this very, very detailed model, it only looks at specific types of data, like the settings and the number of contacts. But as we now saw in the last talk by Beate, actually a lot of determinants are not included in that. So we really have to think about what are the things that we need to measure. And I think that's maybe a bit forgotten with all these very detailed models, that we have to ask ourselves, why are we measuring this, and which questions do we want to answer with it? So we also have to keep the more higher level questions or abstractions in mind to really understand disease spread at the end. So it's always this interaction between trying to go into detail, but also keeping the, let's say, higher level abstract concepts in mind.
I feel that to some extent it depends on something that will be disease-specific and possibly country-specific, that is how generalized is the epidemic. So if you have a generalized epidemic, that is pretty much what happened with COVID in Europe, for example, or in most countries, then this is likely to work reasonably well, because we are actually able to model most of the normal social dynamics quite well. But there can be examples where this will never work. Take monkeypox, for example, the recent monkeypox outbreak. If you don't model specifically that kind of interaction, in that case was mostly a sexual network, that kind of environment, that core community. Or take COVID in Japan, that was spread mostly, at least initially, in bars, in restaurants, in setting like that. So there was a specific core, I wouldn't call it a core population, but a specific kind of interactions. So if it's generalized, things will work well. If it's not generalized and there are some specific dynamics that will drive the interaction, either core groups or possibly special events. I was showing the Euro 2020 period. That is something that is difficult to capture, because it's exceptional events that are not usually what we monitor in infectious disease dynamics. And there are also seasonal trends that I think we are not monitoring that well. So I still have the question, for example, how important is Christmas? You have to essentially model better, I think, holidays, weekends, dynamic, especially holidays, because they are critical in terms of dynamics. So I think we can get there if the epidemic is generalized, and we can get to the point where these models work well. But I think there is still value in monitoring, especially special period or special communities.
Yeah, I think a lot was said already, and I think it depends a lot, as you said, on the research question. And I think also in the future, not all models will be extremely detailed. So you might also, for some research questions, also simpler ones will will be used. And I'm pretty sure this is also going to happen in the future.
Yeah, and maybe to add some to this from the discussion with the decision makers. For example, we were drawn our attention to how do we deal with nursing homes as one vulnerable group. But if we don't have a good information about contacts and transmission within these specific units, then it's harder to evaluate interventions that maybe are focusing specifically here. And also when we think of people with specific comorbidities, that we would also consider vulnerable. And maybe these people, from their intrinsic behavior, they react differently and maybe don't meet that often and so on. But if this information is not included in the model also here, we would miss to model and to see the effect finally of interventions.
Yeah, I also think, because that's why I commented on Elizabeth's presentation earlier on, what we have not been very good at, I think, in the past is measuring contact behavior in very defined, so we have been quite good in measuring it in very defined settings, but not so good in measuring it, for example, in the very old and the very young, and in a generalizable way. Yeah, so of course in single units we did, but not in a generalizable way, and probably that will be, and that's also not possible using population information. Yeah, so by setting a population and agent-based model, we still don't know what's happening in long-term care facilities, for example. Yeah, and I think Niels' team is taking care of that at the moment, so hopeful for the future. But I think these things are maybe what we have to focus on. So the panel is open for your questions as well. So if you have comments, questions, please do.
Yeah, thank you very much again. I have a brief question concerning sampling bias, which can come up in various different contexts. And obviously to a certain degree screw up contact matrices and so on and so forth. I know that obviously things are corrected, therefore, and in the first talk we saw that despite this potential bias, the predictive power seems to be extremely high. So do we not have to worry about that anymore? So maybe you can briefly comment on that.
So if I understood correctly, it was about the role of sampling bias, and that is a difficult one because, by definition, one of the issues with sampling bias is that usually we hope that we know what is our sampling bias. But if we know it, usually we can correct it. So the usual known unknowns, unknown unknowns. My problem with sampling bias is not so much the known unknowns, is the unknown unknowns, especially if you have an epidemic that is spreading in some specific settings. And you may have, so for example, let's take measles. Measles is spreading in patches of unvaccinated individuals right now in different countries. If you use generic contact matrices, maybe derived by surveys that were based on participation, and this part of the population tends to participate less in surveys and things like that. Typical skepticism towards vaccination is related to skepticism towards other approaches. So you end up having your disease that is spreading precisely in a patch of the population that you don't know. In this case, we can guess that there is this hole right now for measles, but my fear is that in many cases you have to accept the fact that there may be effects like that, and it's. It would be lovely to have some kind of common framework, but I think that the problem is that it will really be disease dependent. We are also very good, I think, at measuring some settings, and we are not so good. Essentially, the more the setting is formalized, the better we are at measuring contacts. And the more we focus on longer contacts, workplaces, people that you know well, the more the setting is informal, or the more it's casual contacts, the less good, the less we understand. This is a bias that is, I think, in all studies. And it's difficult to tackle, I think. I think we can make some progress in that direction in the future. The more we will have, we are living in an age where we have massive data. not only the contact tracing app, we actually have now better sources in terms of contacts, and we will have even more sources. And I think we can make progress in that direction, but there will maybe always be patches where we will have to accept that it's not good enough.
I would first have a suggestion. Shall we maybe just all stand down there so we can actually hear?
Oh, yeah, we can do that. Okay. Yeah, we can do that. It's unfortunately extremely difficult to hear the questions up here. I also want to comment on that a little bit because sometimes we think that specific sorts of data collection are especially problematic, let's say surveys for contact data, and that other ways, for example, using GPS-based cell phone data, less prone to bias. But the GPS data we are working with, for example, they are collected via an app which is mainly used only by people who own cars. Yeah. So again, so we know this type of bias and we can potentially take that into account, but since there is no gold standard, in the end, what we are trying to propose somehow is combining different data sources to see how the biases might be in the other data source, and coming up with a unified framework for bringing that together and correcting for that. But it's really, really difficult because sometimes also the biases are going in directions which you wouldn't really expect. So Veronica and myself have worked with Olli Radman at Imperial College on the question, what are the reasons for fatigue somehow? Yeah, so why do people stop to participate, and why do people? What happens if people keep on participating, but are just tired of doing that and still bring in contact data which might not be true anymore? And so we thought that they might change, or that people who keep on reporting might have less non-household contacts. But in the end, what happened is that they report less household contacts if they keep on reporting contacts. So things which you wouldn't expect from looking at that. Yeah? So they just do things wrong. And analyzing that is very, very important, and trying to get a framework which brings everything together is very, very important. But we are now in a situation where we can do that. Yeah? Before the pandemic, we more or less had Polymod and a few more contact surveys around, but we didn't have wide availability of a lot of data in different countries from different sources. And I think for the next years, we have to work a lot on understanding the sampling biases in different situations.
Okay, I think everything was said.
Yeah, maybe what I can add to that is I think that at least in the contact surveys,
apologies.
At least in contact surveys, we usually have egocentric data. So we collect data from the respondents who say something about their contacts, but there is not, the second order connection. So we don't really know from that data how do people cluster in groups, or what is the actual structure of this contact network. So I think that is maybe should get a bit more attention still in contact surveys to see how the larger structures of the network are. And maybe for that, the type of research that Luca talked about, with the apps where you can really look at how are people connected in the network, if this would really work in practice, that would be a great instrument in the future.
I completely agree with that, and I think the best thing that we could get would be some good understanding of the whole contact network, at least locally, of large fraction of the contact network. That is a big question mark in the field that has never been solved. Possibly with some information about who these people are, so who these clusters are. So because there is a lot of assortativity in these networks, so the limitation of the apps is that there were some networks like that. None of them was available for research, unfortunately, but some apps build those networks, but there was no metadata associated. You would like to know age, you would like to know some other information about these individuals. That would definitely be a direction where I think there is potential maybe also from surveys to move in that direction. So surveying contacts of contacts, and so doing more social contact analysis. I think there is the potential, not only through apps, but also through classical surveys. This is something that is being done for example, right now in Africa for HIV. There is more attention towards the whole sexual network and contact of contacts to find the communities. I think this is something we could be doing also right now.
Yeah, for sexual networks, more research has been done. It's in a sense easier because contacts are more defined. So we really have to think of new ways how to do this also for other types of networks.
Yeah, but I think what Luca and what Miriam just said is very important because, again, I don't think there's a one-fits-all solution because apps will, at least at the moment, there's not only no metadata, some parts of the population are generally excluded, so children and also like the elderly, to some extent at least, or very unrepresentative samples of the elderly are just in. So since these are the two most important populations in most infection disease dynamics, again, we have to come up with a clever solution how to combine different approaches, I think.
The place where I think there should be a lot of development and where it could be relatively easy is workplaces. I mean, in the light of the fact that a lot of generalized epidemics go through quite strong contacts, so households, friends, relatives, then workplaces. Workplaces is where I think, compared to what we should know, and the kind of information we should have, we really don't model them with that kind of detail that would be possible. So if I would expect some place where there would be the kind of information available and usable, that would be workplaces.
So we are now a little bit behind our schedule, and therefore I wanted to propose that you discuss this problem further during our dinner or our reception. So this is a very good opportunity. First, I wanted to thank the panelists, so maybe we can do it now. And now there is something, as always, between you and the next meal. There is something still there. And we have a special lecture. So Dr. Stefan Moritz is infectiologist at our hospital, so which is also not very common specialization in Germany. We need more infectiologists, but we also did some special research. And he will report on this. Our dean of faculty mentioned this already, that she participated in our study a few days ago. And you saw it's a picture and a poster, but you can, so Stefan, please you. Stefan, du kannst einfach sprechen. Yeah.
So thank you very much for this invitation, and thank you, Raphael. And Raphael pleased me to give you a talk, but he pleased me to give not a scientific talk here. Well, I was pleased for my entertainment qualities, but in a second step I thought maybe he mistrusts my scientific qualities. I don't know, maybe both. So the restart studies, when science hits the stage, maybe you heard about, we made a big concerts here and measured some data on it. And how did we come to this? It was in April 2020, and the handball league came up to me just when the football started again playing, and said, okay, can you help us making a hygiene concept for the next weeks, they believed. And but it is essential, in contrast to football, we need the visitors within, because they are the basic of our financial support. And I said, no, this is not possible. We are in a pandemic and contacts are essential. In mass gathering, we have a lot of contacts. We do not know much about, but we think there are a lot of contacts. And don't think about weeks, think about 2 or 3 years. And then suddenly 3 adults sat before me with tears in their eyes, and I understood what a ban of mass gathering means for them, for the sports, for the arts. And so I want to say something empathic, and I said, but maybe we can make a study. And they were enthusiastic with this, and I thought further about it and saying, okay, we can make a concert and measure contacts anyway. And I called Raphael and said, what do you think about making a concert now and measuring contacts and during a mass gathering event? And he said, yeah, looks fine, but did you hear about the things they call a pandemic? It's not allowed at the moment. I said, yes, well, let me think about a hygiene concept and maybe we can make this. And really, some days later, we sat there and with a group and we set up this study. And just in a short, we made 3 concert scenarios on one day, and we measured context, we measured aerosol exposition. We did not measure, we calculated on a computer. We built a computer model, a big one, and we measured surface contamination. And we took some more data on all this together, and the demographic data, regional data on mass gatherings. And we gave this data to Raphael, and he set up an agent-based model and calculated the different things. And this was the idea behind this. But I don't want to talk to you about the results. I want to go with you backstage of this event we had. And well, this journey started in July. And in July we had a press conference there, and there were some regional media there, and we were very impressed about this interest in a study. And then we went at home and everything was fine. And then something serious happens. On Monday, The Guardian published an article about our concert. And this acted like an explosion. I didn't imagine, but it happens to be published in The Guardian. Then the next days, every newspaper and journalist around the world, I thought, called us for an interview. There was a New York Times calling. Suddenly we found us in the BBC morning show. And I was in a Chilean evening news, for example. I never expected this in my life. But the attention was good for us. Yes, it was really good because we wanted to recruit about at least more than 1,000, and the best 4,000 participants for our study, and this is a huge goal. But the dilemma was all the televisions, they wanted to have pictures from us. And we didn't have the pictures at the moment. We will have the pictures at the event, but we need it before. And this was the time when I met Uwe these days, and Uwe is a pyrotechnician. And so I thought, well, Uwe, let's make some crazy things with some smoke, some fog, and we did this. We had some lucky days here in a big arena in Leipzig, and we made and we recognized that at 4 o'clock in the afternoon you have a very good sun coming in the hall, and if we make a special mixture of smoke and fog, this looks beautiful. So we told the televisions, and this afternoon at 4 o'clock we make a pre-experiment with the aerosol exposition. And they came there, and we had a wonderful pictures for them, but this doesn't have to do anything with our things. And it was quite similar with contact tracing. I asked the manager of the handball team from Leipzig, can you give me some popular handball gamers? And they said, yes, of course, they have nothing to do. We went to the arena and we gave them these contact traces, and well, they stood like you see here. They stood in a row and they converged and diverged. We make geometrical formations, stars, circles, and all the things that look good. And on a balcony of the arena, there was sitting a technician, and he changed the LED. Blinking red, green, and blinking fast, blinking slow. And these were wonderful pictures for television, but we didn't even record one data at this moment. It was just for television, now I can tell you. And it really helped us, these pictures. We recruited some 100 more participants the next day. So the day came in the mid of August, and we set up this concert, and when I entered the arena the morning, I was a little bit surprised. There were 2 cranes in the arena. Well, I had the idea to set up a concert in an arena, but I didn't realize what that means in reality. And the day went on, and there came a lot of technicians, and the stage was constructed and rigged, and the PA was built up, and suddenly there were 100 of people in the kitchen working for the next day, and the chairs were set up. And then in late afternoon, we stood in the arena and said, what did we do here? We realized that there are about 500 people at this moment in the arena working for this event on the next day. What if we screw up now 1 million euro on the next day if something does not work on the next day? But the next day started good. A little bit rain, a little bit more rain, but it started good. A lot of people came there, and they were in a good mood, and the registration went fine, and everybody got his ticket and was checked for Corona, and he got his trace everybody took with him. And for 10 a.m. we scheduled to open the doors and let the visitors come in for the first scenario. At 9:30, Philip, the man on the left, contacted me. He's the managing director of the arena, that he was called by these well-informed circles. And him was told that a porn star tinkling to the yellow press will try to get Corona positive on our concert in companion with a big German newspaper. And I said, whoa, this is a new challenge. And while we assured while we thought this is a big problem at the moment, it was just the beginning of really a one dark hour. And because some minutes later, here in the middle, this is Cornelius Pollmer from Süddeutsche Zeitung came up to us. And he told us that all the journalists at the event got an email with very detailed data that we did never send out. And so we had to assume that we had a hacker attack at this moment. So we decided to shut down the network at this time and make registration on local data going on and to stay in schedule and open at 10 a.m. the doors. And really that worked fine until 10:15. Then the chief technician came up to me and said, we have a big problem here. Somebody distributed beacons instead of traces, and we have about 80 beacons in the hall, covering a distance of about 18 meters, and we let it like this. The memory of the traces will be full in about an hour. So we said, ooh. This is a challenge to us, and we thought about what making. And finally, a technician came up and told us that there's rain coming through the rooftop. And this was the moment we really thought about canceling the whole thing. And But finally, we had an idea to reset these traces within the hall and delay the schedule 1 hour. And there was a lot of things to do. And I got feedback from my colleagues that a lot of people are angry at the moment outside. There's not enough food outside. They are thirsty. The drinking is just inside. And they are waiting for the show. And they are in a bad mood. So and then the artist says, okay, we are staying in schedule. I'm coming 1 hour later. So everybody, we were forced, has to sit about 45 minutes within the hall without happening anything. So they say to me, you must go on stage. It was not... I was really angry. I feel it going on this stage. First of all, it is an immense impression to stand on a stage for a hall covering about 12,000 people therein. This is an enormous space. And then I thought everybody's in a bad mood. They will boo at me, they will throw eggs on me, and I don't know what they will do with me. But fortunately, they were in a good mood, and again, we did our smoke thing, yes, and everybody was fine. Everybody was good. So when the show started, we had a German singer-songwriter, Tim Bensko. He did a great performance. We did scenario 1, scenario 2. Everything was fine. And then after the second scenario, we had again a press conference. And this was a little bit different because we had 150 journalists therein. And this is the perspective of us. It looks a little bit more like an execution. There, sitting so much people, journalists in front of you, but everything went fine until we come to the last question. A young journalist asked, can I have a last question to Dr. Moritz? And I realized all beside me, they shut down and didn't listen anymore. And the journalist asked me, I'm asking for Playboy Mexico. What is your vision for the future? I didn't know what to answer about this. And the only thing I said, I'm a scientist, I have no visions. Maybe we can ask Tim for his, but Tim didn't listen to that, and he asked me, what did you say? I said, the Playboy is asking for your visions. I said, what? But anyway, he handled that problem, and so this is the way we got to the Playboy, really, and we made a good article there, yes, everybody mentions. So a key outcome from the first restart study was that ventilation plays a key role in making mass gathering safe. So in the second restart study, we focused on aerosol distribution, and we built up such puppets and dummies, one inhaling, exhaling aerosols. But we had one problem, the buoyancy, the thermodynamic buoyancy of the visitors we have to simulate. And we tried a lot of different things to simulate the thermodynamics. A usual human has about 100 watts. But we found it. It is the Charité standard waste bin with a 3-meter wire, heating wire inside. Behaves exactly like a human being. This was surprising in a way, but it does. And so we bought a lot of them and we sent them here to school. Make them more intelligent. We gave them some culture also, and we go to modern theater with our equipment. We even was at the opera, but the managing director was unhappy with us, the musical director. He sat 10 minutes at a chair listening at our equipment, and he listened to... This was all he made. He was 10 minutes listening, then he stood up and said, no. So we left the opera again. And we also were a sports event here, yes. Of course, we equipped our waste bins correctly. Yes, we got 100 fan scarves for our waste bins. And we also were at the museum, at the Brüher Museum in Berlin, and these were our 2 visitors of the museum here. And when I tell you the quintessence from the Restart 2 study is, well, sit in the first row and pray that the actors are healthy. Yeah? This is the quintessence from all of that. And so we had a lot of data, but there was one black point on it. It was we didn't have any data on standing concerts. And what we made in the first concert was seated all, and so we said, okay, we want to have a third concert, another concert with standing, and we went to the Steintor Varieté here in Halle. It's the oldest variety in Europe, now we know, 6 months older than Moulin Rouge in Paris. Yep. If you have time, go there. And yes, we used again our tracers. Here is a team, this time a little bit smaller. We get practice meanwhile with these tracers. And we did one concert, a regular concert on an evening, and everybody got his tracer, and everybody was happy. And we really sold out the variety, 1,300 tickets we sold on this evening, and there was really a good atmosphere in it. Everybody was dancing, and we have the Princeton, German pop band. Didn't expect it, but were a really good atmosphere, and we were praying for good data, and now we can say we have good data, and everything went good in it, and we are checking whether the kind of music is also affecting contexts. Maybe we will see all this, and you see it is full. And when I look back now at 3 restart studies, how can one summarize all the things? I think the best way to summarize all the things is the Princeton made a good summary. So viel Spaß, von Tokio bis Bitterfeld. Behandle dich das Leben ruhig, mach es so wie wir und freu dich. So viel Spaß, für Wenigen, von Tokio bis Bitterfeld. So much fun for so little money. It was not little money, I admit, but it was a lot of fun we had with these restart studies. And what about restart 4? I think the show must go on, yes. And we have ideas, not just the money, but the ideas. And thank you very much.
Thank you. There are no questions allowed here. You can ask Stefan downstairs, and we invite you to to our reception is this called probably.